ولقد خلقنا الإنسان من سلالة من طين ثم جعلناه نطفة في قرار مكين ثم خلقنا النطفة علقة فخلقنا العلقة مضغة فخلقنا المضغة عظاما فكسونا العظام لحما ثم أنشأناه خلقا آخر فتبارك الله أحسن الخالقين ثم إنكم بعد ذلك لميتون ثم إنكم يوم القيامة تبعثون.
السلام عليكم ورحمة الله وبركاته. بسم الله الرحمن الرحيم. دكتور نبيل بسيوني شحاتة، استشاري حديثي الولادة، رئيس قسم الأطفال بالمستشفى السعودي الألماني بالرياض. نيابة عن إدارة المستشفى وإدارة مجموعة مستشفيات السعودي الألماني، اسمحوا لي أرحب بالسادة الحضور وبالمحاضرين الكرام الذين سيشاركون في هذه الندوة، في ندوة قسم الأطفال السادسة، التي ستتناول الحديث والجديد في عالم طب الأطفال وحديثي الولادة، وهو يأتي في ضمن سلسلة مؤتمرات المستشفيات السعودي الألماني لدعم التعليم الطبي المستمر للأطباء ولشباب الأطباء. ونرجو الله أن يجعله مؤتمر مثمرا نتبادل فيه الخبرات لمصلحة جميع مرضانا أو مرضى الأطفال في العالم، ونتمنى إن شاء الله أن تكون الاستفادة لأكبر درجة. نتقدم بخالص الشكر لكل الأساتذة الكرام المشاركين، نشكرهم على مجهودهم وعلى معلوماتهم، وإن شاء الله يجعلوا في ميزان حسناتكم جميعا. Good afternoon, ladies and gentlemen. This is Dr. Nabil Shahata, Head of Pediatrics and Neonatology Department in Saudi German Hospital, Riyadh, consultant neonatologist. Allow me to welcome you all our distinguished speakers and attendees in our 6th International Symposium for Pediatric and Neonatology, who will discuss the modern medicine or modern care in pediatric and neonatology field. Thank you very much for our speakers from everywhere, from USA, from Egypt, from Saudi Arabia, and I wish that it will be a successful webinar, and we will get a benefit all as doctors, and praying to Allah by a speedy recovery and best of health for our patients all over the world. I wish you all good luck, and inshallah we will start our symposium now. Thank you. Our first speaker will be from USA, will be Dr. Anthony Fine. Dr. Anthony Fine is an assistant professor of neurology and pediatrics, Mayo Clinic, Rochester. He will speak to us or give us a good lecture about neonatal seizures. Okay, Dr. Anthony, you can share your speech.
All right, can you see my screen?
Yes.
Okay. Great. Thank you, Dr. Shata. And thank you all for allowing me this opportunity to talk at your conference. I am Anthony Fine. I'm a pediatric neurologist and epileptologist at Mayo Clinic. I have no relevant disclosures. And so the objectives at the end of this presentation, participants should be able to discuss risk factors for neonatal seizures, identify neonates at increased risk for seizures, and recognize presentations of neonatal seizures. So neonatal seizures, the risk is highest in the first month of life. And typically, seizures are occurring in the setting of an acute brain insult. So what we call acute symptomatic seizures, whether it's a stroke that happened in the perinatal period, or hypoxic ischemic encephalopathy as the most common causes. Relatively uncommon, but we do see uncommon things very frequently in pediatric neurology, but the estimated incidence is 1 to 4 per 1,000 live births. Neonatal seizures are challenging in terms of both identification and treatment. If you just watch a neonate, they have lots of funny movements, and in neonate, seizures can be subtle, or they can look like normal baby movements. Other complicating factor is that most neonates, their seizures are subclinical, meaning that there's no outward manifestation and the seizure is going on in the brain, and we could only identify it on EEG. Other complicating factor with neonatal seizures is that our standard therapies that we use to treat seizures may not work as well as we expect. Why do neonates have seizures, and why is the neonatal time the highest frequency of seizures? Well, unfortunately, the neonatal brain is the optimal environment for seizures. It's in a hyperexcitatory state, and there's reduced inhibition. GABA, which is an inhibitory neurotransmitter, typically. However, in the neonate, the action of GABA can actually be the opposite, and GABA can become excitatory. Why is the neonatal brain so excitable? Well, the immature brain needs a pro-excitatory environment in order for proper brain development. So in order for synaptic formation and connections to be made, you need excitatory signals. As we discussed, many causes of neonatal seizures are due to an acute event, and typically these are vascular events. So hypoxia or anoxia during delivery, if there's been an ischemic stroke or hemorrhage. Less common are transient metabolic derangements, so low sodium, low calcium, low glucose, or meningitis. And even less common are genetic and metabolic etiologies. Looking at, this is from a large United States cohort of multiple centers who take care of neonates with seizures, and looking at the etiology and frequency. And so, as you can see, the top 3 causes involve kind of vascular blood perfusion, so ischemic stroke or intracranial hemorrhage, hypoxic ischemic encephalopathy, kind of far outnumbering the other etiologies. Next was genetic disorder, and then less common intracranial infection, a structural malformation, electrolyte abnormalities, or inborn error of metabolism, and then 9% were due to other causes. Most neonatal seizures occur in the first 24 hours. That being said, if a baby is undergoing therapeutic hypothermia, the onset of seizures is typically delayed either later into cooling or particularly during the rewarming phase. And if there is a structural abnormality, the typical presentation is in the first week of life. So if there is a large cortical malformation, a schizencephalic lesion, or there's been an in utero or perinatal stroke, they're more likely to present within the first week. However, other etiologies might appear later. So if a baby is in the neonatal ICU for a prolonged period of time, they can develop meningitis due to other factors. And some genetic epilepsies actually present later. There are a number that present very early in life, but many that present, later in the first year of life into the second year of life. As I kind of mentioned before, neonatal seizures can be funny. And so this is from the American Clinical Neurophysiology Society guideline on treatment of neonatal seizures. And so typical presentations that should raise your suspicion, is this neonate having seizures, would be if they're having focal repetitive clonic movements, so repetitive jerking of an extremity, or they could be having tonic movements, so bilateral stiffening can be seen, but usually it's more unilateral. If there's forced horizontal eye deviation, and so this typically looks different than normal newborn eye movements. If you move their head, their eyes remain deviated to one side. Myoclonus, which can be hard to identify in neonates, just given how twitchy they can be and jittery. Generalized tonic posturing should be seen as an abnormal response. And then brainstem release phenomena. So jitteriness, tremor, again, myoclonus. These are typically movements that are suppressed in the normal brain. Neonates have less of that inhibition, less of that suppression, which is why they have all these extra movements. But if you're seeing a lot of them, it should raise some suspicion. And then autonomic paroxysms that you can't otherwise explain. So episodic tachycardia, apnea, oxygen desaturations, those should raise suspicion that could there be subtle or subclinical seizures going on. Can seizure semiology help tell us a potential etiology? And the answer is yes. There's certain types of seizures which point more towards one etiology versus another, whether it's acute or remote onset, as well as structural versus metabolic or genetic. Other factors to pay attention to are how pharmacoresistant are the seizures? Do they respond to typical first-line therapy, or are you needing to initiate anesthetics? How frequent are the seizures? And then degree of encephalopathy of the baby. So if the baby is really not moving much, very sleepy, and not on sedating medication, should raise a suspicion that there is some sort of encephalopathy, whether it's epileptic or another etiology. Looking at seizure semiology in the neonates, and so semiology are the movements or symptoms, signs and symptoms that go along with a particular seizure. So focal motor clonic seizures are more likely going to be due to an acute symptomatic etiology, and most commonly with stroke, infection, or hypoxic ischemic encephalopathy. Focal non-motor seizures, and so these would be EEG only seizures essentially, again, point to an acute symptomatic etiology, and most commonly stroke or HIE. If babies are having focal motor tonic seizures, so unilateral stiffening of one extremity or the other, in neonates, it tends to not have a predominant laterality, but certainly it can. This implies a more remote symptomatic etiology, most common being genetic, metabolic, or a large structural abnormality. And then if a neonate's having frequent myoclonic seizures, again, remote symptomatic, and you would think more of a metabolic etiology. So with all this information, you may ask, what's so hard about all of this? Why is it so hard to identify neonates having seizures? And unfortunately, the fact is that the majority, 80 to 90% of neonatal seizures are on EEG alone and do not have a clear clinical correlate. So that means that the number of neonatal seizures we're seeing is, 10 to 20% are clinical, which is kind of scary to think about. Additionally, in neonates with clinical seizures, treatment can cause what's called electroclinical dissociation or uncoupling. And this means that the physical manifestations of the seizures have stopped, but they're continuing to seize subclinically. So on EEG, they can still be in status epilepticus, but clinically, you don't see anything. And again, neonates can have stereotype movements that look like seizure, but on EEG are not seizure. And there's an entity of clinical only neonatal seizures, and those can be controversial. But for the most part, they are movements that occur in neonates that look like seizure, but when you hook them up to EEG, you record these movements or events, and there's no EEG correlate. It can be hard to know what to do with that. This truly looks like a seizure, but we're not seeing our electrophysiologic evidence that it is. Continuous EEG monitoring is the gold standard of seizure detection in neonates, and the recommendation is that the EEG duration should be at least 24 hours, given that most neonatal seizures occur within the first 24 hours of life. And so if you do begin EEG, there's a high likelihood of capturing seizures or typical events if you monitor for at least 24 hours. The other thing is that any EEG information, whether this is a formal continuous EEG, if it is a spot EEG for 30 minutes, or an AEEG or amplitude integrated EEG, any EEG information is helpful. And so if you don't have continuous video EEG monitoring available, but you can do another EEG, you should do whatever you have. This is an example from one of my patients. This is typical EEG that we will look at in neonates. And so this is called a longitudinal bipolar montage. You have here your odd numbers, and that represents the left side of the brain. The Z represents the midline, and then even numbers are the right side. We also typically monitor respiratory rate, heart rate, and then look at oxygen saturations. And so this particular neonate was having multifocal onset seizures. And what's interesting in neonates is you can have multiple seizures at the same time occurring independently. And that's indeed what this neonate had. And so looking mainly in the left temporal area, you see these discharges that are kind of quasi-periodic. And then you have this other rhythmic discharge here in the right central region and then in the right temporal. And if you try to see, these are all independent. They're occurring at different frequencies. And then you continue to see evolution of the activity. Then they're spread to the midline. The left temporal activity is stopping, but now you're seeing more right central and midline central activity. That midline central activity is continuing to evolve, and now you're seeing some more periodic activity in the right temporal, frontotemporal region. And then again, activities continuing, midline central, and now you have evolution kind of more right parietal and temporal. And then the left temporal seizure starts up again. So it really can be challenging when treating these seizures, especially when they're very frequent, and in a neonate like this would raise suspicion for either multifocal structural abnormality or like multifocal hemorrhage or infection or metabolic or genetic disorder. Next, we're going to talk about some neonatal epilepsy syndromes, and these are often separated into what we call benign or self-limited epilepsies, and then the developmental and epileptic encephalopathies. And a lot of the naming and has been changed over the years, and there is a current International League Against Epilepsy proposal for naming of neonatal epilepsies. And so I use that terminology, but there are a number of names for multiple syndromes that we're going to discuss. So going first to the self-limited neonatal epilepsy syndromes, self-limited familial or non-familial neonatal epilepsy. This can be inherited, or it can be a new mutation. And as the name implies, they're self-limited. There can be a family history of epilepsy, particularly in the neonatal period. And with these seizures, they typically start in the first 2 to 7 days of life. These can also be called fifth day fits, and you'll still see that being used. Typically, these babies will have pretty frequent repetitive focal clonic or focal tonic seizures. These seizures usually are very responsive to medications and remit by age 6 months, but typically sooner. And then looking at genetic factors that we typically see associated with that are potassium channel mutations, KCNQ2 or KCNQ3. With these particular pathogenic variants, treatment is carbamazepine or oxcarbazepine, and these babies usually respond very well. And usually outcome is good. They are at increased risk of epilepsy later in life, but many will not have any additional seizures. The next epilepsy syndrome is self-limited neonatal infantile epilepsy, and so onset can be really any time during infancy. This is typically autosomal dominant inheritance, and again is focal clonic or tonic seizures. And then as infants get older, they may have focal to bilateral tonic clonic or generalized tonic clonic. Seizures usually go away by 2 years of life. And the genetics here, it can involve KCNQ2, but more commonly involves a familial sodium channel mutation in SCN2A. Treatment again is carbamazepine or oxcarbazepine. With these particular sodium channel mutations, they're typically what are called gain of function mutations. And so using sodium channel blocking medications can actually be helpful. Whereas in other sodium channelopathies, you would avoid sodium blocking medications. Going to early infantile developmental and epileptic encephalopathy. Now, this is on the other end of the spectrum, where we're looking at neonates who are typically encephalopathic, early onset seizures that are resistant to medication. Previously, these were separated into two distinct syndromes, Odahara syndrome and EME, or early myoclonic epilepsy of infancy. Onset typically in the first 3 months of life. Typically, these babies have an abnormal neurologic exam. So they may have hemiparesis, they may have autonomic storming, they may have other exam findings that suggest a genetic or syndromic etiology. And with these disorders, EEG can show a burst suppression pattern, which I'll show on the next slide. Typically, seizures are focal or generalized tonic seizures, particularly asymmetric tonic seizures, myoclonic. They could be focal clonic, or if they're a little bit older, infantile spasms. But typically, these babies develop infantile spasms at a much earlier age. Structural etiology, genetic or metabolic, are most common causes. And so with structural, it's usually we're not talking a stroke, but usually a cortical malformation, lissencephaly, hemimegalencephaly, and treatment really depends on the etiology, but prognosis typically is very poor. And so with Odahara and EME, and now with the new nomenclature, typically death is within the first few months to the year of life, and majority of these babies will die by age 2 due to seizures and complications of seizures. Here's another screenshot of an EEG showing a burst suppression pattern. And now this is a typical pattern if you have someone on anesthetics or you're trying to suppress seizures. But if a baby is in spontaneous burst suppression, that suggests a significant neurologic disorder. Why does it matter what the underlying etiology is and what the underlying genetics are? So for KCNQ2, we had talked about them being responsive to carbamazepine, oxcarbazepine, and whether they have the self-limited epilepsy associated with KCNQ2 or an epileptic encephalopathy, they do respond to sodium channel blockers. SCN2A, you'll have kind of what are called sequential seizures with tonic and autonomic features. Again, respond to sodium channel blockers. STX-BP1 is another genetic epilepsy typically associated with asymmetric tonic seizures and commonly what we call Odahara syndrome. CDKL5 is another epileptic encephalopathy, typically presents in the first few months of life, and it has a unique seizure type to be aware of called the tonic hypermotor spasm sequence. And so they'll go from a tonic seizure to a hypermotor seizure to an epileptic spasm. And that's pretty unique to CDKL5. And then KCNT1 is another potassium channel disorder. It can be associated with migrating focal epilepsy of infancy or nocturnal frontal lobe seizures. And these typically present with focal tonic seizures and autonomic symptoms. Need to talk briefly about metabolic etiologies. And so if you have a baby who is encephalopathic, seizures of unknown origin, and they're not responding to your typical anti-seizure medications, then you should strongly consider a Paradoxine trial. And it's typically recommended Paradoxine 100 milligrams per day for 3 to 7 days. If there is response, so reduction of seizures, EEG is looking better, then maintenance Paradoxine is recommended unless an alternative etiology is identified. So going to Paradoxine-dependent epilepsy or PDE, this is due to biallelic variants in ALDH7A1, also known as antiquidin. And then an allelic disorder is PNPO or pyridoxamine 5' phosphate deficiency due to biallelic variants in PNPO. Both of these onset within the first few days of life. Similar presentations, hyperkinetic movements, and multifocal myoclonus. Again, seizures do not respond well to anti-seizure medications that we commonly use in neonates, and you'll see markers of encephalopathy on EEG and in the baby. You could confirm this diagnosis by testing pipicolic acid and alpha aminoadipic in either the spinal fluid, urine, or blood. And treatment for both is Paradoxine, as well as lysine-restricted diet. There's some evidence for supplementation with arginine, but there's less agreement on that. But if you suspect these disorders, it's recommended to treat while testing is pending. If there is response or they have one of these disorders, then they would continue on Paradoxine lifelong. Prognosis, yes, they could respond to Paradoxine, but these children are usually quite impaired. So moderate to severe intellectual disability is common, and they typically will have breakthrough seizures with times of stress, so major illness, surgery, sleep deprivation. Another disorder to be aware of is non-ketonic hyperglycemia. And so this is a commonly tested disorder, but very rare. And so you'll get a history of excessive hiccups in utero or fetal hiccups, which are very common during pregnancy, but usually there's a history of very, very frequent hiccups. And then these neonates also have myoclonic seizures. Again, you'll see a burst suppression pattern. Testing is with CSF, so cerebrospinal fluid testing of serum glycine and CSF glycine and comparing the CSF to serum glycine ratio, and it'll be elevated. This can be due to one of 3 biallelic variants, and more commonly is the AMT and GLDC, and rare is the GCSH variant. And treatment really is aimed at reducing plasma glycine levels. So you will treat them with anti-seizure medications, but you're also trying to reduce the the glycine to reduce that excitotoxicity. Sodium benzoate can help reduce seizures. It does not improve outcome. Other medications that can be helpful in some patients are ketamine, dextromethorphan, and felbamate. Unfortunately, this disorder does have a poor prognosis, and mortality is fairly high. Briefly talk about treatment for neonatal seizures, and only briefly because this is quite variable dependent on your center, as well as there is variability even within countries. So, in the US, at our multiple centers that we work with, it's not uncommon that each center has a variation of a similar strategy, but there are differences in the treatment. It could depend on provider comfort level, availability of medications, and then the experience of the center. This is International League Against Epilepsy proposed treatment of neonatal seizures, and so certainly not necessarily the gold standard, but this is at least an international consensus recommendation. And first line is phenobarbital. There's been significant shift in evidence. Levetiracetam was being used very frequently and is still used very frequently for treatment of neonatal seizures. There have been more recent studies that show that phenobarbital is actually superior to levetiracetam, which contradicts previous literature. But at our center, we are now again using phenobarbital as first line. Second line, significant variability, no clear expert consensus opinion, but phenytoin, phosphanytoin, levetiracetam, midazolam, and lidocaine are commonly used second line. If you suspect a channelopathy, then it's recommended to try phenytoin or carbamazepine. And then if the baby has a cardiac abnormality, a rhythm defect, then levetiracetam is recommended. Another kind of shift in practice is that after acute symptomatic seizures are treated, you should withdraw anti-seizure medications prior to discharge. And this is going to be very dependent on the neonate and their subsequent risk for seizure. And so if a baby is at high risk for recurrence, you're certainly not going to take them off anti-seizure medications prior to dismissal. But there certainly is a push to get neonates off anti-seizure medication before they leave the hospital, rather than waiting anywhere from 3 to 6 months to a year or two to withdraw anti-seizure medications. The highest frequency of seizure recurrence is within the first 6 months. And so the babies who do need ongoing anti-seizure medication will declare themselves fairly early that they need to remain on anti-seizure medication. But the majority of neonates can come off anti-seizure medication following neonatal seizures. So that's my talk. I know that was a lot of information in a short period of time. My main points, neonatal seizures are difficult to identify, and really you need EEG monitoring available to identify the majority of neonatal seizures, because most of them are subclinical or electrographic. And then really it's important to identify the underlying cause of the seizures, and that can help in terms of guiding your treatment and management, as well as helping with prognosis. And, in neonates with seizures, you should have a high suspicion for an epileptic encephalopathy. If EEG is severely abnormal, there's spontaneous burst suppression, seizures are not responding to anti-seizure medications, and the neonate is clearly encephalopathic, and you don't have a history of hypoxic ischemic encephalopathy or other vascular event, then you should have a strong index of suspicion for an underlying epileptic encephalopathy. Now just pause for questions. Thank you very much.
Thank you so much, Professor Anthony, for your great talk. We have one question here from Dr. Samira.
Thank you, Dr. Anthony. My question is, if we have one neonate with hypoxic and the EEG machine is not available with us, and the patient, the clinical examination has moderate to severe encephalopathy, and we started calling therapy for that patient, and we don't have clinical seizures, do you prefer to start anticonvulsant for this patient or not? Because I can detect some clinical seizures at this point.
Yeah, that's a great question, and certainly if you don't have EEG available, that there's no outward manifestations, they're undergoing therapeutic hypothermia, do you start kind of prophylactic anti-seizure medication? Is that correct? Is a question?
Yes. The patient has moderate encephalopathy with severe encephalopathy. I don't have clinical seizures into examination. I don't have to detect clinical seizure. Can I use Phenobarbitone as a prophylactic during the cooling? Because I don't know if there is some.
Oh, I can't hear you. Do you use, Phenobarbitone as, neuroprotection? Certainly if that's a very good question. I don't have a great, this is, personal opinion. Certainly if you are waiting for EEG to be available or you just don't have EEG, we know phenobarbital can be neuroprotective to the neonate at risk for seizure or having seizures. And so I don't think you'd be wrong to start something. You could start phenobarbital, certainly. It's our practice, here is very different in just in terms of we have all of our babies with hypoxic ischemic encephalopathy. They're on continuous EEG monitoring during cooling. Certainly during cooling, you have a window of time where there's a lower risk of seizure, and really that risk of seizure is typically, after 48 hours compared to in the first 24 hours in a non-cooled neonate. And so if it's a matter of waiting, you don't see clinical seizures, EEG will be able to occur, in 12 hours or 24 hours. I don't think it's unreasonable to wait, but that's just my opinion.
Thank you so much. In continuation with this question, if I will start Phenobal, I will load and start full dose or just on, for example, 3 mg?
So I think if you're starting the anti-seizure medication, makes sense to do, a load. And usually I would do 20 milligrams per kilogram load. And then for maintenance, I think, yes, phenobarbital has a long half-life, but really if you're concerned for seizures, would start maintenance. I think reasonable to start 3 to 5 milligrams per kilogram per day. You certainly can go higher, but starting probably a lower dose first.
Okay, I have another question from Dr. Baghdad. Dose of Paradoxine you are using, it has to be very high to control convulsions. How to prove that convulsions is due to its deficiency? The proof is by analysis, I think, by test.
Exactly. So it's really a therapeutic trial. It's what we call therapeutic and diagnostic trial. So you're certainly not going to have your metabolic testing back, or you might not even have it started. And so if the dose of Paradoxine, we usually will do 100 milligrams, and that's IV, and you'll continue at IV for several days. You may not see an initial response, but many times you do see improvement in EEG background, and seizures will be reduced in frequency. So based on both EEG and clinical findings, you'll say there's a response to Paradoxine. Could it be coincidental? The other anti-seizure medications they're on, things are finally reaching steady state plasma levels. Sure, but that's why you kind of continue that trial and then send off your testing to try to prove whether it is actually paradoxine deficiency.
Thank you. Sorry for taking a longer time with you because this is an important issue actually in units. So we have another question from
Absolutely.
Dr. Anthony, in seizures, first attack of seizures for neonates, because we are two separate groups. One group is referring to get loading phenobarbital, for example, and they will wait until if there is no repeated of the seizures, they will not give maintenance. And if related, they will reload and give maintenance. And another tool for us that some of us preferring that we start loading Phenobarbitone and they will continue on the maintenance treatment for 3 days, for example, and if there is no convulsion, they will stop. So what is your guidelines in your area?
So so the question was just kind of loading with phenobarbital and continue on maintenance for 3 days if there is clinical seizure, and then asking kind of what our practice is. Is that correct? Okay.
Yes.
And so certainly you want to withdraw phenobarbital if you can. And so here we may continue it a little bit longer depending on the neonate. And so if it really just depends on whether you're seeing clinical seizures or if they are having electrographic seizures to inform the duration of phenobarbital. But many times, and what our practice has been, we'll have them on phenobarbital for 1 to 2 weeks, and then try to take it away. We may, if they're on multiple anti-seizure medications, such as levetiracetam, phenobarbital, we would certainly withdraw phenobarbital first. But we also kind of withdraw phenobarbital at the first opportunity, if that makes sense.
Thank you. One last question. If you will send the unit home on medication, would you prefer to send with Phenobarbitone or levetiracetam?
It depends on the response to treatment. If they responded well to levetiracetam, I think levetiracetam's a pretty fairly benign anti-seizure medication. In terms of side effects, it's not going to interact with other medications. It doesn't affect blood counts, liver, kidneys, and really doesn't cause significant sedation, whereas phenobarbital can often make babies pretty sleepy. And so if they responded well to levetiracetam and we think they need to continue on anti-seizure medication, I probably would prefer levetiracetam. However, if they've clearly responded very well, they had difficult to treat seizures, and the only thing they're responding to is phenobarbital, then I would continue the phenobarbital. I then will usually see them back around 1 month. If we can get a routine EEG, we'll get just a short EEG and see what's going on. If there's no clinical seizures, EEG is normal, then would be very comfortable in weaning medication.
Okay. How frequent should we examine the plasma level? And if I want to stop the medication, how long will be the weaning period? Over 2 weeks or more or longer period?
So,
and this will be our last question.
Yes. No. Great questions. So for serum levels of anticonvulsants, it's usually I'll wait 2 to 3 days after, if they've received an IV load of a medication. If you were to check a level the next day, it's going to not necessarily be steady state. So for phenobarbital, I usually wait 48 to 72 hours before checking a level. And similar for levetiracetam, if they've been loaded have gotten multiple loads, then I wait 2 or 3 days before checking a level, and would make sure to check if a trough level, so before they get their next dose of medication, to see the lowest level in the blood before making adjustments. With the other thing to think about in neonates is that they are typically rapid metabolizers of medication. And so you sometimes will have to go to 3 times a day dosing for levetiracetam and phenobarbital, depending on how quickly they seem to be metabolizing the level. So sometimes if the level is low, just increasing the frequency of dosages can help.
Okay. Thank you so much, and we're glad to be with us. We hope, inshallah, we'll cooperate in the future other than our symposiums.
Great.
Thank you so much.
Thank you so much. Take care.
Bye-bye. You can stop sharing this. Yes. So we will move to the next.
Our next speaker will be Dr. Nabil Shafata. Dr. Nabil has a podcast in Pediatric and Adolescent Medicine, Essen University, Germany. He is a consultant neonatologist and head of the Department of Pediatric and Neonatology in SGH Riyadh. He is an NRB instructor in National Guard Center and American Academy of Pediatrics. He will talk about management and outcome of sepsis in late preterm and term infants.
Assalamu alaikum. Because sepsis is one of and the most challenging issues in most of the ICUs all over the world. So we will take it an overview, and we will try to summarize as much as we can. Our lecture and our practice here is going with the guidelines of the American Academy of Pediatrics and CDC, and this is the last version. So sepsis is an important cause of morbidity and mortality among newborn infants. Although the incidence of sepsis in term and late preterm infants is low, the potential for serious adverse outcome, including death, is for such great consequences that caregivers should have a low threshold for evaluation and treatment for possible sepsis in neonates. Our approach, as we told, is according to the American Academy of Pediatrics and the Center for Disease Control. Symptomatic infants, what is the supportive care? How we will treat a baby with sepsis? We have antimicrobial care and we have the supportive care. Symptomatic infants should be treated in a care setting with full cardiopulmonary monitoring and support, because the clinical course of these infants can deteriorate rapidly. Although there are no data demonstrating the importance of supportive care measures in neonates with sepsis, it is generally accepted that the following supportive measures are of critical components of management. First, maintaining adequate oxygenation and perfusion, prevention of hypoglycemia and metabolic acidosis, maintenance of normal fluid and electrolyte status. Severely ill patients may require ventilation or ventilatory and volume or vasopressor support to maintain adequate oxygenation and perfusion. Diagnostic consideration in infants with suspected sepsis, additional testing for other conditions may be warranted based on the clinical signs and symptoms. Signs and symptoms of neonatal sepsis are often non-specific, and here is why it is difficult, because you cannot wait for specific signs and symptoms to diagnose sepsis. As summarized in the table, it will come below. It may be difficult to differentiate neonatal sepsis from other diseases. However, given the morbidity and the mortality of neonatal sepsis, empiric antibiotic therapy should be provided after cultures are obtained to infants with suspected sepsis, pending definitive culture-based diagnosis. Alternative diagnosis should be entertained when an infant with suspected sepsis has negative culture. Type. If I will do lumbar puncture, if not done during the initial evaluation, a lumbar puncture should be performed in infants, however possible, with culture proven or culture negative clinical sepsis. Clinical signs suggesting meningitis can be lacking, and the blood culture may be negative in infants with meningitis. Right. Whom to treat? The decision to start antibiotic therapy is based on the assessment of the risk factors, clinical evaluation, and laboratory test. Indications for empiric antibiotic therapy include ill appearance, concerning symptoms including temperature instability and respiratory, cardiopulmonary, or cardiocirculatory, or neurologic symptoms. Cerebrospinal fluid, if the white blood cells count is more than 20 to 30 cells per microliter, confirmed or suspected maternal chorioamnitis, and positive blood culture or CSF culture. Here, if you will see, we can see the CSF components or accepted components in neonates. As we see, from 0 to 24 hours, it is accepted to see 5 to up to 90 white blood cells. The absolute neutrophilic count can be 3 per cubic millimeter. The main protein can range from 32 to 240. The main glucose, the main 50, and range between 30 to 78. When from 0 to from 1 day and to 10 days, it will be as high as 8 or to 32. It will not be accepted anymore, this 90. And absolute neutrophilic count will be 61.3% accepted. The main protein will be 90 and glucose 52. In terminals evaluated in emergency after discharge, will not accept more than 5 cells, and the absolute neutrophilic count 2%. The main protein will be around the 70, and glucose 42. Preterm and very low persuade, lower than 1,500 grams. The number will be a little bit higher. As we see, white blood cells can be up to 30. Protein will be 144, glucose 50. If it is more than 1 day, will be 5 and 148 and 67. All meningitis will have a decrease in glucose and increase in protein, even if the cells are not accurate. The initial empiric therapy, the initial choice of parenteral antimicrobials for suspected sepsis in term and late preterm neonates is based on the infant's age, likely pathogens, susceptibility pattern of the organism in a particular nursery or a particular center, and presence of an apparent source of infection like skin, joint, or bone involvement. Here, this is a suggested regimen of the antibiotic which will be used. We have to differentiate between early onset sepsis. The baby will be age lower than 7 days, and late onset sepsis more than 7 days. In some centers, they can consider more than 72 hours will be late onset sepsis. And then admitted from the community or admitted from the hospital or hospitalized. If the patient is in early onset sepsis, ampicillin and gentamicin will be the preferred regimen or the routine regimen. If also late onset sepsis but admitted from the community, a preferred regimen will be ampicillin and gentamicin, the same, and we can add cephalosporin if we need. In late onset sepsis, if the patient is coming from home, so the same regimen will be applied, ampicillin and gentamicin, and maybe combined all instead of gentamicin and extended cephalosporin like cefepime, ceftazidime, or cefotaxime. If the patient is hospitalized from the start, that means he may have a multi-drug resistant infection. So the preferred regimen will be gentamicin and vancomycin, and can be also added cephalosporin or third generation or fourth generation cephalosporin. If suspected pneumonia, ampicillin and gentamicin will be good. Alternative will be ampicillin and third generation cephalosporin or fourth generation FCFB. Vancomycin will be added if the patient is, as we told, long time hospitalized. Suspected infection of soft tissue, skin, joints, and bone, vancomycin has to be added all the time, and the duration will be much longer than the regular sepsis. Suspected endovascular catheter-related infection, vancomycin and gentamicin will be the best. Suspected infection due to organism found in the gastrointestinal tract, we have to add something like clindamycin or flagyl, and piperacillin tazobactam can be an alternate for ampicillin and gentamicin. If we take it pathogen dependent, if we suspect group beta streptococcus, penicillin is the best. E. coli, ampicillin sensitive, ampicillin will be the best. E. coli, ampicillin resistant, expanded spectrum cephalosporin, ceftazidime, cefepime, or cefotaxime will be the best. And alternate will be meropenem if the patient is critically ill. Multi-drug resistant gram-negative bacilli, including ESBL reducing organism and Listeria monocytosis and MSSA with MRSA, will use here meropenem for the first one, and we have to use ampicillin and gentamicin, or can add vancomycin in case of MRSA or MSSA. So from here, we will see that ampicillin and gentamicin will be quite enough for a long chain of bacteria. So don't escalate unless you have a reason and you have a deteriorating baby. Otherwise, a multi-drug resistance will appear very quickly. Early onset sepsis, our recommended empiric regime is for suspected early onset sepsis is ampicillin plus gentamicin. For term and late preterm neonates, lower than or younger than 7 days old, the dose of the ampicillin will be 100 milligram per kilogram per dose, given intravenously IV every 8 hours. Gentamicin dosing is 4 milligram per kilogram per dose, IV every 24 hours. We generally obtain baseline renal function test, the blood urea, nitrogen, and the creatinine levels at the initiation of the treatment with gentamicin. Serum gentamicin level should be obtained in infants receiving a full course of antibiotics, but are not required if the treatment course will be only for 48 hours, is anticipated, and renal function are normal. The combination of ampicillin and gentamicin is effective in treating most common pathogens that cause early onset sepsis, including group B streptococcus, Listeria, Enterococcus, and most isolate and E. coli of E. coli. Here, as we told, the most common causing organism and the less common causing organism for early onset sepsis will be the GBS, E. coli. In term infants. In preterm, E. coli will be more frequent than GBS. Still in all can be another bacteria like Enterobacter and Klebsiella, Listeria, but we are speaking in the first column about the most common. In term and late preterm, in late onset sepsis, E. coli and GBS, additional pathogens seen in the ICU as per like Staph aureus, Klebsiella, and all. In preterm infants, Staph coagulase negative will be the first, then Staph aureus, E. coli, Klebsiella, and GBS. If we take it pathogen-based source of infection, meningitis will be GBS, E. coli, other gram-negative enteric bacilli can cause it. Pneumonia, GBS. Urinary tract infection, E. coli. Skin and soft tissue, Staph aureus, and GBS, and group A, Streptococcus. Vascular catheter associated infection will be Staph aureus, Staph coagulase negative, and Enterococcus gram-negative. Intestinal bacteria, E. coli, Klebsiella, and other enteric gram-negative bacilli, Clostridium species, and anaerobic species. Early onset sepsis, it is in the available study, 90% of isolate from the culture proven early onset sepsis was suspected as are susceptible to ampicillin and gentamicin or both. Ampicillin and gentamicin are preferred over ampicillin and third generation cephalosporin, cefotaxime, or ceftriaxone based upon the following. The regimen of ampicillin and third generation cephalosporins is not more effective than the combination of ampicillin and gentamicin, and the emergence of cephalosporin resistant gram-negative organism is very rapid if I will use the cephalosporin as a routine, like Enterobacter, cloaca, Klebsiella, Serratia can occur when cephalosporin will be used as routinely. Ampicillin and gentamicins are synergistic in treating infections caused by GBS and Listeria monocytogenes. Cephalosporin are not active against Listeria. In large cohort study, infants who received ampicillin and cefotaxime had a 1.5-fold increase in mortality compared to those treated with ampicillin and gentamicin. Ceftriaxone is a highly bound to albumin and appears to displace bilirubin. Although displacement of free bilirubin by ceftriaxone has not been reported, it is advisable to avoid ceftriaxone in neonates at risk of acute bilirubin encephalopathy. The addition of an expanded spectrum cephalosporin, cefotaxime, ceftazidime, cefepime to the regimen ampicillin gentamicin is warranted for infants with suspected meningitis. And if I have the meningitis, I have to use the triple therapy. And critically ill neonates with risk factors associated with ampicillin-resistant infections, like prolonged rupture of membranes and prolonged antenatal maternal ampicillin treatment. If there is concern for meningitis caused by multi-drug-resistant gram-negative organism, carbamazepine, merovinam, is preferred. Tynam is not preferred in neonates because it can cause convulsions if the patient has CNS infection. So Tynam is not the preferred one. Merovinam is the preferred. But late onset sepsis, the choice of empiric therapy for late onset sepsis depends upon whether the infant is admitted from the community and thus at a lower risk of infections caused by multi-drug resistant pathogens, or the patient is hospitalized since birth and has a higher risk for getting infection from the unit. Neonates admitted from the community are lower risk for infection caused by multi-drug resistant pathogens than are infants who remain hospitalized. The combination of ampicillin and gentamicin or ampicillin and expanded spectrum cephalosporin are regimen for empiric treatment of sepsis without an apparent focus of infection in this setting. The preferred regimen is generally ampicillin plus gentamicin. However, local antibiotic resistance or sensogram or biogram of the center will or can modify the combination. How should be considered. For term and late preterm neonates more than 7 days old, the dose of ampicillin will be 75 milligram per kilogram per dose IV every 6 hours. Gentamicin dosing will be 5 milligram per kilogram per dose IV every 24 hours. We generally obtain baseline renal function test, blood urea nitrogen, and the creatinine levels at the initiation of the treatment with gentamicin, and serum gentamicin level should be obtained in infants receiving a full course only if you expect that the treatment will be for 48 hours or less. No need to do plasma level, provided that the renal function was normal. In a national surveillance study in USA from 2006 to 2008, 96% of isolate from the late onset bacteremia were susceptible to a combination of ampicillin and gentamicin. The addition of expanded spectrum cephalosporin, cefotaxime, ceftazidime, cefepime to ampicillin and gentamicin regime is warranted for suspected meningitis. If there is a concern for gram-negative meningitis caused by multi-drug resistant merovinam should be added. Hospitalized since birth, infants who continue to be hospitalized since birth are at higher risk. That's why a multi-drug resistant organism, and therefore vancomycin will be instead of ampicillin, and I can use also merovinam. The initial IV loading dose of vancomycin is 20 mg per kilogram. Subsequent doses depends on the serum creatinine level. If the serum creatinine is blue 0.7 milligram, 15 milligram per kilogram per dose every 12 hours. If it is 0.7 to 0.9, 20 milligram per kilogram per dose every 24 hours. If it is 1.3 to 1.6 milligram per deciliter, 10 milligram per kilogram per dose IV every 24 hours. If the serum creatinine is more than 1.6 milligram per deciliter, 15 milligram per kilogram per dose IV every 48 hours. This will be the recommended dosing. Admitted from the community, alternative neonatal dosing recommendation for vancomycin based on weight and gestation age available in lexicon. Continuous infusion dosing regime have also been described, but further clinical trials are needed before the method can be employed. In spite, we can give this in multi-drug resistant vancomycin, and merovinam can be also continuous infusion. Continuous infusion may be associated with earlier treatment of target concentration and lower total daily dose compared with intermittent dosing. However, it is unclear whether the results in more rapid clearance of infusion compared to standard dosing. Most studies on continuous vancomycin infusion have focused on methicillin MRSA infection. The importance of achieving a particular vancomycin exposure for successful treatment of coagulase negative staphylococcus infection is not well established. Alternative regime based upon specific clinical circumstances. If I have suspected meningitis in neonates with late onset sepsis in newborn, the lumbar puncture suggests meningitis. CSF have high white blood cells, and expanded spectrum cephalosporins, cefotaxime and ceftazidime or cefepime should be included in the regime, and triple regimen will be used. Adding an expanded spectrum cephalosporin to the regimen, ampicillin and gentamicin, broadens the empiric coverage for gram-negative organism and provide optimal activity in CSF against pneumococci. If there is a concern for meningitis caused by multi-drug resistant gram-negative organism, merovinam or carbaminam will be the preferred agent for empiric therapy. If the sepsis is suspected pneumonia, empiric regimen for treatment of infants with a pulmonary focus of infection include ampicillin and gentamicin. Ampicillin is an extended spectrum cephalosporin vancomycin, and an extended spectrum cephalosporin or vancomycin and gentamicin will be the preferred regimen. If the infection in the skin and soft tissue, bone, and joints, if there is a focus of infection involving the skin, soft tissue, bone, or joints, in which case Staph aureus is likely pathogen, vancomycin should be substituted for ampicillin, and for very long duration, especially in bone. If there is osteomyelitis, we can use up to 6 to 8 weeks until clear eradication of the infection. In toxic appearing infant, nifacillin should be also added. If the infection is catheter-related infections, if intravascular catheter-related infection is concerned, treatment should be initiated with vancomycin and gentamicin to provide empiric covering for coagulase negative, staphylococci, staph aureus, and gram-negative bacteria. Suspected intestinal source, I have to add, as we told, an antimicrobial for anaerobic bacteria, clindamycin or metronidazole will be added to the regimen before. Type. For how long I will treat? If I have a culture-proven sepsis, in units with culture-proven sepsis, the usual course of therapy is 10 days. Longer treatment course may be warranted if a specific focus of infection is identified, like meningitis, osteomyelitis, or septic arthritis. As we told, meningitis can be 2 weeks to 3 weeks. Osteomyelitis, septic arthritis can be up to 6 to 8 weeks. Antimicrobial therapy should be altered based upon the susceptibility profile and pathogen isolate. For the most common causative organism of neonate sepsis, antimicrobial therapy is as follows. Group beta streptococcus, the drug of choice will be penicillin. Thus, when GPS is identified and resolution of bacteremia is documented by repeat blood culture and an infant with meningitis, CSF is sterile, we recommend discontinue gentamicin and continue the therapy with penicillin alone for the whole course. Here we can say that which antibiotic will be preferred and what is the dose for bacteremia and bacterial sepsis and meningitis in late onset and in early onset, as we spoke before. If E. coli, in patients with ampicillin-sensitive E. coli sepsis who have improved clinically and who meningitis has been excluded, ampicillin monotherapy is administered for 10 days course. For patients with ampicillin-resistant E. coli, the choice of the definitive therapy is based upon the susceptibility profile. An expanded spectrum cephalosporin, cefotaxime, or ceftazidime, cefepime is often employed for the if the isolate is susceptible. Other gram-negative bacilli, antimicrobial treatment of infections caused by Klebsiella, Proteus, Enterobacter, Serratia, Pseudomonas, and Shigellosis. For all these infections caused by infections caused by multi-drug resistant gram-negative bacilli, including those caused by extended spectrum beta-lactam producing organism, or those with hyperproduction of beta-lactamase, merovinam will be the drug of choice. The combination of ampicillin and gentamicin is used in the initial survey for listeria. Treatment with both agents is more effective than ampicillin alone in vitro and in animal modules. Cephalosporin are not active against it, so it's not wise to add cephalosporin to this, and the duration of therapy will be 10 days. Staphylococcus species, directed therapy by infection caused by Staphylococcus is determined by the sensitivity of the eyes to specific antibiotic agents. Staph aureus, vancomycin, or intoxic apparent infant, vancomycin plus nifacillin should be used. For Staph aureus infection, until the susceptibility profile is available, the regimens then should be adjusted according to the susceptibility profile. Staphylococcus species, FMSSA, treatment infection should be completed with nifacillin. Cefazolin is an alternative for the treatment of MSSA infections outside of the central nervous system and not involving endocarditis. MRSA should be treated with vancomycin. Coagulase negative staphylococcus infection require treatment with vancomycin. Right. If I have a probable unproven sepsis, an infection with negative blood culture, but a clinical status that go with sepsis concerning for systemic infection, ongoing temperature instability, ongoing respiratory cardiocirculatory or neurologic symptoms not explained by other conditions or laboratory abnormalities, antibiotic therapy should be extended for as long as 5 to 10 days. Usually we are stopping after 1 week. After 36 to 48 hours, the empiric regimen is altered based upon the whether meningitis has been excluded or not. If meningitis has been excluded, the ampicillin dosing regimen can be reduced to 100 mg per kilogram per day to 12 hours. In infants less than 7 days old, or 50 milligram per kilogram per dose IV every 6 hours in infants more than 7 days. That means in early onset or late onset. If lumbar puncture has not been performed, ampicillin should be continued at a meningitic dose. Alternate diagnosis should be entertained when an infant with suspected sepsis has a negative cultures. Antibiotics should be discontinued when another diagnosis is established. If sepsis is unlikely, empirical antibiotics are initiated in many infants with maternal risk factors, abnormal laboratory values, or mild to moderate symptoms that subsequently resolve. Sepsis is unlikely in these infants if they remain well and the blood culture is sterile after 36 to 48 hours. Here, empiric antibiotics should be discontinued after 36 to 48 hours. In response to therapy, in most cases, symptomatic infant with proven sepsis improve clinically within 24 to 48 hours. In infants with bacteremia, a repeat blood culture should be obtained after 24 to 48 hours of therapy to document sterility. Failure to sterilize the bloodstream suggests that the antimicrobials chosen are not active against the infecting pathogen or that there is an unrecognized focus of infection. Consultation with pediatric infectious disease specialist may be warranted. Adjuvant therapy. The following adjuvant immunotherapeutic intervention have been studied in neonatal sepsis, but should not be routinely administered because they have not been shown consequently improve of the outcome. Like IVIG, a lot of centers are using IVIG in severe sepsis, but it is unproven. Granulocyte transfusion, granulocyte and granulocyte macrophages colony stimulating factor, اللي هو CSF and GM-CSF. Prevention. How to prevent? The primary intervention to prevent neonatal sepsis is the use of intrapartum antibiotic prophylaxis in OB/GYN in mothers with group beta streptococcus, colonization, and other risk. Although intrapartum antibiotic prophylaxis has been resulted in a decrease in the incidence of early onset GBS invasive neonatal infection, it has not had a similar impact on the rate of the late onset sepsis. Probable or but unproven sepsis. Comprehensive prevention of neonatal sepsis will require a multi-interventional program, including effective maternal vaccination, reduction of preterm delivery, and limited exposure of term infants to potential pathogens. Probiotic and lactoferrin have been investigated as potential preventive interventions in preterm neonates. However, neither approach has been consequently proven to reduce the risk of sepsis, and those interventions are not routinely used in clinical practice, despite a lot of units are using them now. The outcome: overall mortality in term and late preterm infants with neonatal sepsis is approximately 2 to 3%. Mortality estimates vary depending on the gestational age of the infant. Lower gestational age is associated with higher mortality. Pathogens E. coli is associated with higher mortality than group beta streptococcus. And sepsis definition: lower mortality rates tend to be reported if infants with culture negative clinical sepsis are included compared to cases of culture proven sepsis. Mortality rates of group beta streptococcus sepsis in term infants after the introduction of antibiotics intrapartum and routine use of empiric antibiotic therapy regime for 2 to 3% for early onset diseases and 1 to 2% for late onset. So the mortality decreased. The risk of mortality is higher in infants with birth weight lower than 2.5 kg. Absolute neutrophil count lower than 1,500 cells per microliter, and if hypotension, apnea, or pleural effusion is present. The risk of mortality is particularly high in neonates with early onset sepsis caused by E. coli. Estimated mortality rates for term neonates with E. coli sepsis are about 6 to 10%. Thank you so much, and sorry for being long.
Thank you, Dr. Nabil, for your lecture. This question for Dr. Agda is asking you, are you using the GPN surgeon and restricted infection during sepsis in our unit or not?
In our unit, we are not using it because maybe it is not available, but it is recommended if you have it and you are sure that it is active, we can use. But in our unit, our regimen is ampicillin gentamicin or ampicillin cefotaxime if extreme preterm, and vancomycin if a late onset sepsis and suspected MRSA or staph coagulase negative. Okay, so we'll go to the next speaker. Let me stop sharing. Our next speaker. Our next speaker will be Dr. Samira Ghallab. Dr. Samira Ghallab is a consultant general pediatrics, and she has a long experience in neonatal unit. She is our colleague in Saudi German Hospital, Riyadh. Dr. Samira has Egyptian fellowship in pediatric and neonatology. She will give us a case presentation about a case happened in our unit. She will speak to us about esophageal perforation in neonates. Okay, Dr. Samira.
طيب. بسم الله الرحمن الرحيم. I will talk about esophageal perforation in neonates. I will start my presentation with introduction of clinical cases. We have 3 clinical real cases of esophageal perforation. All of them are preterms. Then I will speak about the risk factors of esophageal perforation, clinical diagnosis, management, and the complications. The first case is a 24-week-old female with birth weight of 650 grams. She was delivered outside our hospital and received 3 doses of surfactant and referred to us on the 7th day of life on mechanical ventilation. The baby was receiving usual preterm care and support. From the history, there was sometimes difficulty in OGT insertion. This is the X-ray on admission. The OGT level, as we can see, it is at the level of the diaphragm here. It was no X-ray done showing this OGT more than this. On the 19th day of life, the patient developed sudden desaturations with raised left chest wall and sudden severe abdominal distension. And we did the X-ray urgently and showed this picture. We have here in the X-ray subcutaneous emphysema, we have pneumothorax, and we have pneumoperitoneum. Chest tube was inserted for pneumothorax, and after which the patient was stabilized clinically, and no intervention done for the pneumoperitoneum. This is X-ray bilateral after the insertion of the chest tube, and this is the lateral film. Between 24 and 48 hours from the incidence, the pneumoperitoneum was completely resolved, as we can see in this X-ray. Even the pneumothorax is resolved. What about the circumstances around this incidence? The X-ray was done about 20 minutes before the incidence, and during which the OGT was removed accidentally, and the staff nurse attempts to reinsert another OGT just before the incidence, during which there was some resistance, then release during the insertion. And we diagnosed the case as esophageal perforation clinical diagnosis. We did follow up. We kept the patient in PO for 2 weeks, and we started TPN with broad spectrum antibiotics covering the gram-positive and the gram-negative bacteria and covering anaerobes. Then after 2 weeks, we did contrast study for the esophagogram to detect if there is esophageal here or no, and there was no signs of contrast leak. So after that, we started the feeding. The second case was also preterm male patient with 24 weekers, product of CS delivery. The birth weight was 700 grams with RDS, and he was intubated in the DROR and received surfactant through the ETT. OGT was inserted, and after stabilization, baby was shifted to the NICU. He is maintaining oxygen saturation and low FiO2, and the X-ray was done to confirm the ETT position, OGT levels, and the chest condition. This is the X-ray. As we can see, the OGT is passing through the mediastinum in the pleural space, and there is tension pneumothorax on the right side. As the patient was stable and maintaining his vital signs, the decision of the observation by the team leader was the rule. X-ray repeated after a short period. It was after about 15 minutes, showing this picture. There is the resolution of the air. And he did the X-ray at that time. He removed the OGT and he inserted another one. Cautiously, he inserted and he's in the stomach, as we can see here. And then after about 3 to 4 hours, we have another X-ray for the same patient showing completely resolution of the pneumothorax. This is the AP view. There is no signs of pneumothorax here, and then this is the lateral view. So this patient was spontaneously relieved without intervention regarding the perforation. The third case was a preterm also, 24 weekers. This patient is our patients in the unit. 24 weekers male was product of spontaneous vaginal delivery. Birth weight was 615 grams, and he was electively intubated and received surfactant for the RDS and the DR, developed pulmonary hemorrhage and early neonatal sepsis, and was treated. At the age of 10 days, there was trial to insert the ATT, which is failed, and the patient has severe oral bleeding at that time, but finally was intubated. And this is X-ray showing the RDS, ATT, and the OGT. It is in position in the stomach. This before the incidence. Suddenly, there was increasing in the abdominal girth and chest wall and diffuse swelling in the chest wall and subcutaneous. With the progressive bradycardia and desaturation. The patient received CPR, he was arrested and received CPR, and the X-ray was done after the insertion of the ATT. And as you can see, there is a severe massive pneumomediastinum, pneumothorax, subcutaneous emphysema massive, and pneumoperitoneum. And we can see here, I will in the second picture here, there is the OGT after insertion. This is passing through, perforating the esophagus and passing through the mediastinum to the upper abdomen. This is apparent here on the arrows. This patient was died after the resuscitation, after a few hours from resuscitation, he was died. So the esophageal perforation in neonates is rare, but potentially fatal. The mortality rate is reaching about 28%. This is the anatomy of the esophagus, this is adult esophagus. Usually the anatomy of the esophagus is divided into three parts: cervical part, thoracic part, and abdominal part. Abdominal part is small part, about 5 cm only. The thoracic part is divided into other three areas: upper thoracic, middle thoracic, and lower thoracic. The division is according to the stricture sites. Yani cervical esophagus is starting with the upper esophageal sphincter, it is narrow area, and the thoracic starting with the side of the aortic arch and the left main bronchus, origin of the left main bronchus, it is narrowing area also, and the abdominal starting with the passage of the esophagus through the diaphragm, lower diaphragmatic hiatus. The esophageal length is affected by age, sex, and physical condition. In adults, the length is about 25 to 28 cm length, and diameter is 2 cm. It is located between C6 and T11, and in the neonates, it is located between about C5 or C4 to T9 or T10. Its length at the neonatal birth is 18 cm, then it is increased to 22 cm by the age of 3 years, and reaching the adult length by the age of 10 years. This diagram is showing the stricture sites or constriction areas of the esophagus. We have the first one, as I told you before, the upper esophageal sphincter, which is the second narrow part after the appendix in the body. Then another three parts is the aortic arch, left main bronchus origin, and the third is the diaphragmatic hiatus here. These are the sites, usually the sites of perforation or resistance happening, and the perforation happening in this site. The most common in neonates is the upper esophageal sphincter, but the most severe is the thoracic perforation. So the risk factors for esophageal perforation in neonates, it is usually heterogenic. There is one study done for pediatrics and neonates in general, showing about 80% were due to intubation and esophageoscopy for pediatrics, and neonates, particularly those under 1.5 kg, are especially risky for perforation during ATT insertion, gastric tube insertion, oropharyngeal suction, or if the patient has esophageal atresia, the risk will be increased during the insertion of the ATT. The sites of the esophageal perforation, as I told you, the three stricture sites, the most common is the pharyngoesophageal junction. The manifestation of esophageal perforation, commonly reported symptoms of esophageal perforation in neonates are sudden onset of respiratory distress due to the pleural effusion and the pneumothorax. Sometimes it will be present if the patient is not intubated. It will be present with apnea, prolonged apnea requiring ventilation. In the first 24 hours in general after perforation, the neonates tend to present with fever, hypersalivation, choking, coughing, or cyanosis after feeding. The patient with thoracic perforation, which is most severe site, may present with subcutaneous emphysema and signs of respiratory distress more. Patient with intra-abdominal esophageal perforations may present with peritonitis, dysphagia, and drooling. The diagnosis of esophageal perforation is mainly clinical, the X-ray, and the sphagogram. Usually we are doing the 3 cases I presented. We diagnosed clinical diagnosis and the X-ray showing the signs of the air leak. And the sphagogram, we are doing, some centers are doing the sphagogram in the start of the diagnosis, but we are, because we are guarding against the chemical inflammation from the contrast, we are doing it after 7 to 14 days from the perforation to detect the healing process. So we can start feeding up after that. Contrast enhanced CT, it is more accurate than others, but it is difficult in preterm babies, and especially the babies, the preterm babies usually are unstable after the perforation. Apart from the contrast we are injecting to them. Ultrasound, transabdominal ultrasound, it is a new era for the diagnosis of esophageal perforation by experienced radiologists. So the radiological findings may include pneumothorax, pleural effusion, subcutaneous emphysema, pneumopericardium, pneumomediastinum, and pneumobritone. And of course, if not treated good, there will be signs of inflammation and infection or sepsis after that. This case was reported in one of the journals, accidental esophageal perforation in extremely low birth weight neonates. This OGT is passing through the pleural space in the right lung, as we can see here. This center, they diagnosed clinically, and they, after 7 or 8 days, they did the esophagogram, and they showing no leak through the esophageal pathway. This also was 26-week patient, 8,600 grams. This neonates, preterm neonates are very fragile neonates and easily traumatized. This is another case reported also, esophageal perforation after transesophageal echocardiogram, and this is a sphagogram showing the leak here in the upper mediastinum. This study was done to evaluate the use of ultrasound for the diagnosis of esophageal perforation. As we know, the X-ray will detect the leak. The contrast will detect the leak if there is a leak, but they will not detect the amount of the fluid if there is effusion or fluid leak in the mediastinum, and it will not detect the mediastinal abscess. Here, the rule of the ultrasound, transabdominal ultrasound, to detect exactly the mediastinal abscess, that if present, we must operate the patient. So the management of esophageal perforation neonates, mainly non-surgical treatment. The principles of management of pediatric and neonatal esophageal perforation includes rapid diagnosis, appropriate hemodynamic monitoring and support, antibiotic therapy covering gram-negative, gram-positive, and anaerobes, and using the local hospital antibiogram. Total parenteral nutrition, and on follow-up to do contrast study before starting feeding after 7 to 14 days to detect the follow the healing. If we did and there is still healing or leak, we can wait another 7 days and do the study again to decide the start of the feeding. So the complications, usually in neonates, the prognosis is, as we told, is 28% death, but the spontaneous healing is usually the rule. But if not appropriately treated, we have mediastinitis can occur, empyema can occur, mediastinal abscess, and sepsis. If there is mediastinal abscess happen, here the surgical intervention is a must. My message here, small babies are fragile, need expert gentle deal. Esophageal perforation, although it is rare, it is life-threatening and needs rapid response and rapid treatment. Management is mainly non-surgical, NPO, TBN, empirical antibiotics are the main medical treatment after emergency stabilization. Ultrasound chest is an ongoing, promising, safe radiological way, replacing the X-ray used in the diagnosis of different chest disease. Thank you.
Thanks a lot, Samira, for your excellent presentation. We don't have so far questions, so we are also a little bit late. So we'll move to our next speaker. Our next speaker will be Dr. Saeed Al-Ghoueri. Dr. Saeed is a consultant nephrologist. He has a German pediatric board in Bonn University, Facharzt, and he has a pediatric nephrology fellowship in Nottingham University, UK. He's also the ex-nephrology consultant in Prince Sultan Military Hospital in Riyadh. Dr. Saeed will speak to us about UTI in infants and children, diagnosis and management. Okay, Dr. Saeed.
Assalamu alaikum wa rahmatullahi wa barakatuh. I'd like to thank the organized and scientific committee for their efforts and continuity of this nice meeting every year. Today, I'd like to share you with the most important and common disease in the children, urinary tract infection.
Can you just minimize the picture and the Spanish?
So UTI is the most common bacterial disease in childhood worldwide and may have significant adverse consequences, particularly in young children. Also, the delay in the diagnosis and management of UTI may potentially result in renal damage and loss of renal function. The significant bacteria. So to diagnose the significant bacteria, the diagnosis of significant bacteria depends on the method of urine sample collection and the quantitative urine culture result on the basis of number of colony-forming units that grow in the culture medium. Asymptomatic bacteria, isolation of significant quantitative count of bacteria in appropriately collected urine specimen from an individual without symptoms of UTI. Urinary tract infection, either upper or lower infection, either upper in kidney or lower in a bladder. So lower UTI is an infection of the urinary bladder mucosa with symptoms including dysuria, frequency, incontinence, hematuria, or suprapubic pain. In newborns and infants, these symptoms are rarely diagnosed accurately. Pyelonephritis is a diffuse pyogenic infection of renal pelvis, parenchyma, and symptoms of fever, flank pain, and tenderness. So you can diagnose clinically when the patient is presented with very high temperature, low in pain, and tenderness. You can diagnose pyelonephritis. In infants and young children, these classical manifestations may be absent, and differentiation between cystitis and pyelonephritis is often difficult. So if the patient, any patient, young infant patient presented to your clinic, even with irritability or crying, poor feeding, or frequent vomiting without any other causes of these symptoms, please do urine culture. Recurrent urinary tract infection, 2 or more episodes of symptomatic UTI within 12 months. complicated UTI, UTI in a critically ill patient, UTI in patients with evidence of urinary tract obstruction, UTI in patients who fail to respond after 48 hours of starting an appropriate antibiotic therapy. There are 4 main methods of urine sample collection: either clean catch or clean voided urine, urinary bag, catheterization, suprapubic aspiration. So urinary bag always and most common is contaminated. So we have to educate the mom how to do this properly, how to take the sample properly. We have to educate the mom how to take the nappy out and clean with water. Don't use antiseptic, dry it, fix the bag, and feed the baby without covering this genitalia area. Once the urine come to the, when the baby pass urine in the bag, put it in a sterile container and deliver to the lab within 30 minutes. The causative agents in urinary tract infections: E. coli, Klebsiella, Pseudomonas, Proteus, Enterobacter, or Staph. In the Saudi pediatric population, E. coli is the most frequently isolated uropathology, reported in 70 to 80% of the infants and children presented with urinary tract infection. What are the risk factors? Age and gender is very important. So the female infant has higher prevalence of urinary tract infection than male infants. Febrile females less than 12 months of age had the higher baseline prevalence of UTI. Uncircumcised male infant with fever has up to 8-fold higher prevalence of UTI than circumcised boy, with the highest prevalence in those less than 3 months, which are the risk age group. Urinary tract obstruction, either BUG obstruction or posterior valve. Children with function or anatomical obstructive urological abnormalities, such as posterior valve or ureteric junction obstruction or neurogenic bladder, are at high risk to develop UTI. Retention and stasis of urine and suboptimal clearance of bacteria from the urinary tract are excellent factors for the most urinary pathogens. That's why in neurogenic bladder, we have to teach the mother how to do CIC, clean intermittent catheterization, to evacuate the residual urine in the bladder to avoid any recurrent infection. Vesicourethral reflux. Few are predisposed patients to recurrent UTI. Bowel and bladder dysfunction is an important risk factor for recurrent urinary tract infection in children, which is characterized by constipation, frequent voiding, urgency, dysuria, incontinence, and withholding behavior. It usually presents in otherwise healthy school-age children. Obtain a urine analysis and culture, the treatment of UTI. First of all, you have to obtain urine analysis and culture and initiate empiric antibiotic based on local resistant patterns of urinary pathogens. If it is available, that's it. You have to look for the previous culture and look at the sensitivity, then choose the antibiotic which was sensitive to. No treatment recommended for asymptomatic bacteria in infants and children. Otherwise, they will have recurrent UTI. Check any previous urine culture and susceptibility finding, because it will depend on the treatment on this susceptibility or sensitivity. Select antibiotic appropriately. A breakthrough infection while patient on antibiotic prophylaxis needs a treatment with different antibiotics, so we have to change the antibiotics. So cystitis, treatment of cystitis is 5 to 7 days enough. We are using augmentin, cefprozil, or nitrobentoin. In pyelonephritis, third generation cephalosporin can use ceftriaxone, amino glycosides like gentamicin. And if the patient is, you can treat pyelonephritis, by the way, without admission in the hospital if the patient if there's not ill sick, or if it doesn't any frequent vomiting or whatever. If it is clinically is okay, you can treat it at home for 10 days. If he is happy, if he is sick, ill or sick or having frequent vomiting, admit the patient and start ceftriaxone. Once you have 3 days consecutive 3 days febrile, you can complete the course at home 14 days. Data showed a very high prevalence of resistance against ampicillin or cotrimoxazole bacterium, 70 and 60% respectively. Imaging studies, renal and bladder ultrasound is non-invasive, safe, and easy test that can detect renal and urinary bladder abnormalities. What are the indications of renal ultrasound? First, febrile UTI in children less than 3 years old, children at any age with one or more of the following: either recurrent UTI, UTI and family history of UR, first-degree relatives, febrile UTI caused by an organism other than E. coli, and complicated UTI. MCUG, 33% of Saudi children presented with UTI have PUR. So we have grades 1 to 5, and you have to will show male urethra anatomy, and we'll show any urinary bladder abnormalities like cystitis. They show what's the problem there. So what are the indications? Recurrent urinary tract infection, complicated UTI, abnormalities of renal bladder ultrasound results, hydronephrosis, renal scarring, obstructive uropathy, febrile UTI caused by an organism other than E. coli, children with UTI and family history of UR in first-degree relatives. DIMS scan, dimercabritosuccinic acid, to do it to diagnose acute pyelonephritis, and we don't use it anymore because pyelonephritis you can diagnose clinically by very high temperature, low in pain, and tenderness. To look for the renal scarring, you have to do. If you have any recurrent UTI or recurrent pyelonephritis, you have to look for renal scarring. Febrile UTI in children with severe PUR, grade 4 to 5, impaired renal function related to urinary tract infection, elevated serum creatinine, hypertension, or proteinuria. Timing when we'll do this DIMS scan, 4 to 6 months after acute infection. So antibiotic prophylaxis. Before start antibiotic prophylaxis, usually we'll teach the mom regarding the preventive measures. The most important for this preventive measures is regular and full voiding of the urine, and to avoid any constipation. Then, if it is not, then we start antibiotic prophylaxis. So we don't recommend routine antibiotic prophylaxis in infants and children with normal urinary system or mild PUR grade 1 to 2 after the first UTI. So what are the indications of antibiotic prophylaxis? Children with moderate to high grade reflux, grade 3 to 4 to 5. Uncircumcised male with any grade of PUR. Children with bowel bladder dysfunction and any grade of PUR, with any grade of PUR, of course. What are the choice of antibiotic prophylaxis? We recommend to check the previous urine culture and susceptibility result and to choose antibiotic accordingly. So we'll use nitrofurantoin 1 to 2 milligram per kg per day, or bacterium 2 milligram per kg per day. Amoxicillin and cephalosporin should not routinely be used in prophylaxis because of the increased risk of development of resistant organism. But these regimens can be used in infants less than 2 months of age, or in patients who cannot tolerate or develop adverse effects related to the use of trimethoprim or nitrofurantoin. The conclusion: UTI are common in infants and children. UTI should be suspected in children with unexplained fever and in older children with urinary symptoms. An appropriate urine sample should be collected for diagnostic microscopy and culture before initiating an empiric antibiotic. Diagnosis of the UTI should be made based on the combination of clinical symptoms and positive quantitative urine culture according to the recommended method of urine sample collection. Once UTI is diagnosed, an appropriate antibiotic therapy should be initiated as soon as possible to prevent complications and renal scarring. Renal bladder ultrasound is recommended after first febrile UTI in all children less than 3 years and in children with complicated or recurrent at any age, as well as in child with febrile UTI caused by an organism other than E. coli. VCUG or micturating cystourinogram is not routinely recommended after first UTI. It is indicated mainly in specific conditions like abnormal renal bladder ultrasound, result, recurrent UTI, and others. Prophylactic antibiotics don't seem to be beneficial after first febrile UTI in children with mild VUR, although it may be considered in high-grade reflux after the assessment of the possible risk and benefits. Thank you.
Thank you so much, Dr. Saeed, for your nice presentation. Do you have any question? Okay, so we'll proceed to our next speaker. Can stop sharing. Our next speaker will be Dr. Tariq Al-Tukhais. Dr. Tariq is an associate professor of pediatric surgery in King Saud University in Riyadh. He is a consultant of pediatric surgery in King Khalid University Hospital. And he will speak to us about neonatal surgery where, in ICU or in OR. Welcome, Dr. Tariq.
Thank you, Dr. Nabil. بسم الله الرحمن الرحيم.
بتسمعوني كويس? Yes, I can hear you, but you have to share your presentation.
طيب. Now the screen, you can see the screen now?
Not yet.
طيب, maybe I need to be allowed to share the screen.
I think you are allowed, you are a panelist.
طيب, screen, just a second. Start podcast. What about now?
Yes, I can see, but yes, the presentation, but make it full screen.
Oh, okay, good. طيب, بسم الله الرحمن الرحيم. Thank you, Dr. Nabil and the organizing committee for the invitation for this 6th annual webinar. And inshallah, it will be successful as the previous ones. Today, I'll talk about non-surgical. It's not a pure surgical issue. It's more of logistic issue. Because
معلش في حاجة طالعة من على الشاشة من الموبايل. أيوة دي بعدها كده في أي حتة.
أحاول أبعدها. أيوة تمام خلاص.
أيوة تمام.
تمام. So what is the ideal location for operative intervention in neonates? Is it the main operating theater in the hospital, or is it in the bedside, or is it a special room in the NICU itself? So the concept of utilizing the NICU as an alternative place to operating room in critically ill neonates is not something new. It's been there for almost 50 years. So over the last 4 decades, various reports on successful ligation of PDA in the NICU unit were published. However, reports of utilizing the NICU for performing procedures other than PDA or peritoneal dialysis or perforated neck are very limited in the literature. Transferring these unstable neonates to and from the OR may be associated with significant morbidity, which may alter the outcome in these already compromised patients. So in view of this consideration, some of the pediatric surgical centers have utilized NICU as an alternative place to carry out surgery on the critically ill neonates. So what are the critical steps before operating the child? As any child, decision to operate or not, then the ideal location, is it in the NICU or in the main OR, and the mode of transportation. As we can see here, this unstable neonate is connected to so many machines and monitors, machines, IV lines. So it's not an easy job to transfer this neonate to the main operative room. To make the issue is more complicated if the child or if the neonate is also connected to a high-frequency ventilator or other special machines like nitric oxide. So transport of the surgical neonates, either in the intra-hospital transfer to and from the OR, is associated with many problems. For example, extubation of the endotracheal tube or dislodgement, dislodgement of vascular access, IV lines or PICC lines, which are really difficult to reinsert, discontinuation of the ventilator and monitor, and sometimes the ventilator in the main OR is not compatible to the ventilator used in the NICU. In addition to hypothermia, which we have seen many times. Also, the time-consuming. Imagine transportation of this critically ill neonate with so many machines to the OR. It will take a very long time, and it will delay the OR. So the aim of the study is to reduce the morbidity associated with transfer of critical ill neonates to the OR. So what are the maximum benefits if we do the surgery in the NICU? So it's good for emergency cases, especially in critically ill patients. Also for those who are extremely low birth weight, less than 1 kilogram, and neonates who are on special ventilators like high frequency or on ECMO or on nitric oxide. Also, if the main OR is long way to go through, and as we know, some hospitals, the main OR is in different building, so the neonate has been transported to another building, either by ambulance or by a special transportation. So what are the advantages? The main advantage is to avoid the transport, the risk of transportation, as we mentioned before, and also to have a better peri and post-operative care, because the neonate will be cared by the same nursing team, the same neonatology team, so there will be a continuation of care. There will be no discontinuation or dislodgement of the vascular access or the endotracheal tube. And there will be no disturbance of the temperature of the neonate, so the thermal environment will be the same. And no physical disturbance of infant, which reduces pain and acute metabolic stress. And there will be no operative delay. It will not affect the schedule of the main OR. What are the disadvantages? There are few reports reported that the systemic and wound infection rates are higher if we operate on the NICU, either bedside or a special room in the NICU. But we can argue with that, with these numbers, because these patients are usually sicker than the usual cases where we transport to the main OR. So they are more prone to wound infection, even if they are transported to the main OR. One of the disadvantages is disruption of the daily routine round in the unit and the daily work in the NICU. Also compromise ability to meet the technical challenges, especially if we have a demanding surgical procedure which needs a lot of either instruments or special instruments. Maybe the limited space is a disadvantage. So what are the indications to operate in the NICU? Either elective or emergency surgery, especially in neonates who are really sick and require like a ventilator, like high frequency ventilator or nitric oxide. So in general, unstable neonates are the main indication to be operated on the NICU. What are the requirements for surgery in the NICU? We have to choose either we do it bedside or designated area, like procedure room or operating room within the NICU, which is the ideal. But it depends on the NICU, depends on the limitations. Also, other technical issues like surgical scrub and other surgical equipments like lights. These are the requirement of the surgical unit in the NICU to resemble that one in the main OR. So we need a scrub and circulating nurse, anesthesiologist, and neonatologist. Also the anesthetic drugs and inhalational drugs as well. And also fresh filtered air for exchange if available. So we use the same universal precautions if we operate bedside or in the main OR, same precautions like the universal precautions, prepping, draping, and etc. These are the common bedside surgical procedures like venous cut down or venous access, PDA ligation, peritoneal drainage insertion, repair of omphalocele or gastroschisis, and ECMO in some centers. Also, the bedside surgical procedures are not limited to those we mentioned. We can do anything, any surgical procedure, if the equipment are prepared. We had experience over the last few years where we practiced as bedside surgery in the NICU because of the high morbidity that we noticed during transportation from the NICU to the main OR. We started as bedside for a few years until we have our own OR room in the NICU. This is the start where we do it at bedside and we cover the area with the sheets and we bring the whole surgical team to the NICU unit. As you can see here, this space almost limited, but we can do it. Also, the bed is not movable like the one in the OR, but all these we can compromise because the patient is unstable. As you can see, this patient is already on high frequency plus nitric oxide, and this patient in particular has a diaphragmatic hernia, which we repaired bedside. Later on, we had our own OR room. So these are the numbers of our patients. Gestational age range from 25 weeks to 42 weeks, and the mean was 33 weeks. And age at surgery mean is 10 days. And almost half of them were in inotropes, and all of them were on mechanical ventilation. Our indication was in critically ill patients who needed emergency surgery only, and those who are very low birth weight on special ventilators like high frequency or nitric oxide. And these are the types of procedures, 47 cases, excluding a cut down and peritoneal catheter. The numbers are much more than this. So what's the outcomes? The outcomes in general are good. We had 3 mortalities, 2 of them because of perforated necrotizing enterocolitis, and 1 due to congenital diaphragmatic hernia. All of these 3 cases were not related to the surgical procedure. These patients were really sick, even preoperatively. And we had wound infection and wound disruption in a very low birth weight with perforated necrotizing enterocolitis. And these mortalities and morbidity are comparable to those who are transported to the main OR. So there was no difference between doing the procedure bedside or transportation to the main OR. If we look at the literature, there is a paucity and rarity of published information on either to support or to refute the practice of bedside surgery in the NICU. So sequence of reports of ligation of PDA in the NICU with results similar to that done in the OR. And most of the published literature, there was no significant difference between doing the case in the NICU or in the main OR. And these are just examples of other reports. And these are the cases published in the literature where the cases done in the NICU, about 81 cases, and compared to the 112 cases done in the main OR, although the death rate is higher, but this is expected because these patients are sicker than those who are able to be transported to the main OR. So we cannot compare an outcome with a sick baby with another one who's not sick. So this is the summary of the published reports. And as you can see, the numbers are not that high because not a lot of the centers doing procedures in the NICU. So we have a lot of missing information until now, and we have no clear evidence what is the ideal place to operate. So which is better, the NICU OR or the main operating room? And does surgery in the NICU increase the risk of local and systemic infection? We really don't have a clear answer, but the answer we have clearly that doing it in bedside or in the OR in the NICU is much easier for the neonate. So in conclusion, performing major surgical procedures in the NICU is feasible and safe. Maximum benefit is in very sick, critically ill neonates. And there is no special area needed in the NICU to perform complicated free surgery. And designing an operating room within the NICU for both elective and emergency surgery is ideal. And for the successful development of the practice of the NICU surgery, careful planning and cooperation of the entire team caring for the patient is needed. And the absence of reliable information on this subject urge for prospective randomized control studies evaluating the bedside versus OR intervention. And thank you.
Thank you so much, Dr. Tariq, for this nice presentation. And خلاص, we have the new OR who are waiting for you. We have the new OR opened already in our new NICU expansion, so you will not suffer anymore.
MashaAllah, MashaAllah. This is a good planning. Yeah, good planning. If you have any expansion to the NICU, an OR should be kept in mind.
Yes, we added this OR in this expansion, and now we've done 3 or 4 laser surgeries, and we are waiting for you, inshallah.
MashaAllah. Congratulations.
Thank you so much. Shukran. Shukran. Thank you. So our next speaker, you can stop sharing your portal.
Yeah, sure.
No, sorry. Our next speaker will be Dr. Rami Mustafa. Dr. Rami Mustafa is consultant general pediatrics with neonatal experience. He is one of our consultants in Saudi German Hospital, Riyadh. He has also Egyptian fellowship. He will speak to us about high-risk preterm follow-up program in the OPD. Okay, Dr. Rami.
Assalamu alaikum wa rahmatullahi wa barakatuh. First of all, I would like to thank Dr. Nabil for his kind invitation for this webinar, which is growing year after year. We will talk today about the high-risk preterm follow-up program. Our learning objective in this topic, we will talk about the program and first which babies need for this follow-up program and where I will should be to do this follow-up and who will do it and how we will use this protocol. Advances in neonatal intensive care have improved the survival of high-risk preterm, who's at risk for post-discharge long-term morbidities such as growth failure, neurodevelopmental impairment, visual and hearing problem. So an appropriate and comprehensive follow-up program is essential for high-risk infant, not only to ensure intact survival and optimal growth, but also optimal quality of life for these infants. Which babies need follow-up? We can categorize these babies. First, the biological risk factor. First, the preterm less than 34 weeker, low birth weight less than 1.8 kg, severe IUGR and severe IUGR less than 3rd percentile and major malformation. Also, the babies has morbidities like asphyxia, shock, respiratory distress required support, jaundice near to exchange level, significant BDA, necrotizing enterocolitis, hypoglycemia. Intervention, babies need intervention like inotropic support, multiple anticonvulsant, prolonged antibiotic course, need resuscitation in postnatal period, and also we must take in place the socioeconomic factor like poor families which need support and multiple birth and low maternal confidence. Who should do the follow-up? There is a long list of the doctors and specialists in this list, in this program, but the main rule in this list for the pediatrician, which is the nodal person of the team to assess the screen, to assess the growth and screen for developmental delay and manage intercurrent illness, and also refer the needed cases for subspecialty. Also, the pediatric neurologist, psychologist, ophthalmologist, and ENT, also dietitian and swallowing therapy, physiotherapy, and speech and occupation. This, before we starting to do the to go to the program, we need to talk about the planning of discharge. Which baby is able to discharge? First, able to maintain temperature in open crib with normal ambient temperature, adequate cardiorespiratory control without episode of apnea and bradycardia, adequate intake to promote appropriate growth and demonstrate a consistent pattern of appropriate weight barrier to discharge, able to sleep in flat and supine position. Second thing, I need in the discharging plan to check if the baby complete all the routine screening, including the metabolic and genetic disorder, retinopathy or prematurity, hearing screening, other screening tests based on clinical setting may include brain imaging and laboratory studies like CBC and alkaline phosphatase. Routine immunization based on chronological age consistent with the schedule and those recommended for normal full-term infant. Identify specialized needs for individual patient include medication, formula, medical equipment, and cases of incurable terminal condition which will need hospital care. Very important test or screening must be passed by the baby before discharge. It is the car seat or bed screening, which is done for all babies less than 37 weeks of gestation. Also for any baby has comorbidities, cardiorespiratory or airway or muscle disease. The duration of screening is ranging from 90 to 120 continuous minutes. Infant consider fail if the oxygen saturation below 90 or 93% for more than 10 seconds. Apnea greater than or equal to 20 seconds. Bradycardia less than or equal to 8 beats per minute. If the infant fail in the car seat screening, we will use the car bed. Discharge should be delayed, and an investigation for cardiopulmonary abnormalities should sought in any infant who persistently fail the car seat or bed cardiopulmonary screening test. Family must be a part of the planning and the program. So we need the family, we need the parent to be educated well and demonstrated competency in the daily care of their infant, demonstrating knowledge of normal behavior of their infant and the ability to recognize signs and symptoms of illness that require medical consultation, understanding safety, sleep position to avoid sudden infant syndrome. Second thing is the home environmental preparation. Obtain the necessary supplies and equipment needed for the daily care of their infant. Evaluation of social and financial need that may require additional support and if needed. The follow-up schedule. Here we will differentiate between the high-risk group, which are infant below 1.8 kg birth weight and gestation below the 35-week. The initial visit must be within 48 to 72 hours of discharge. Subsequent visit, it will be 1 to 2 weeks until the weight of 3 kg. Then at 4, 6, 9, 12, and 18 months, then every 6 months until age of 8 years. The initial visit must include review of the infant in ICU course, current medication, growth parameter, clinical status, nutrition, development, immunization record, and neonatal screening. Time, and also we must give time for listening and address the family concern, review the patient future appointment with subspecialty. The subsequent visits. The subsequent visit, every baby will discharge it must have this card like that, have the subsequent visit timing and which component of the subsequent visit. In the subsequent visit, we will check the nutrition of the baby. The first of nutrition is the type of feeding. For all infants, better to receive maternal breast milk as long as the mother can provide it during the first year of life. For preterm infant, the ideal to discharge with fortified breast milk, but it's very difficult, so we can use the partial exclusive breastfeeding by giving 2 to 3 feeds per day with preterm formula to ensure adequate caloric intake for growth. However, when breast milk is not available, preterm formula can be used for at least 9 months corrected age. Other NICU graduate will be discharged on a special formula for a special reason like necrotizing enterocolitis and feeding intolerance. For infants who are received supplemental nutrition and diuretics therapy, follow-up laboratory testing may be needed, include hematocrit, reticulocytic count, electrolyte, calcium, alkaline phosphatase, and vitamin D level. Also, the preterm are facing feeding difficulties, leading to poor growth and are more common among extreme preterm less than 28 weeks due to swallowing problem, oral motor dysfunction, hypersensitivity. All these problems will lead to decrease of the development of the baby and will need to early intervention and to refer to swallowing team. Monitoring of growth. Growth parameter includes the infant weight, length, and head circumference, and should be monitored on weekly or bi-weekly basis for the first 4 to 6 weeks after hospital discharge. After this initial period of close observation, infants who are growing normally can be monitored every month and then every 2 months. Correction for gestational age should be made for weight through the 24 months of age, for stature through 40 months of age, and for the head circumference through 18 months of age. We recommend use of Fenton preterm infant growth chart until the infant is 44 to 48 week post-menstrual age, and at which point the WHO growth chart for term infant can be utilized. Bi-weekly or monthly follow-up visit should continue for infant with slow weight gain, so remain below the third, which remain below the third percentile on a standard growth curve. When they have reached 40 post-menstrual week, or who have chronic health problem like bronchopulmonary dysplasia, close monitoring should continue until a steady, adequate growth pattern is established. Infants who fail off their growth curve are growing suboptimally and should be evaluated and treated as soon as possible to achieve or catch up hair growth. Infants who are extremely short may need further evaluation for growth retardation by the pediatric endocrinologist. As regards the head circumference, slow head growth is associated with developmental delay. In one report, very low birth weight infant whose head circumference were below normal by 8 months corrected age had poor cognitive function, academic achievement, and behavior at 8 years of age, compared with control with normal head size. Immunization. The medically stable preterm infant should receive full immunization based on their chronological age, consistent with schedule and those recommended for normal full-term infant. There are specific issues with some immunization in preterm infant that are highlighted below. First, the hepatitis B. Hepatitis B, the first dose is given according to the birth weight and the status of hepatitis B surface antigen of the mother. For infant who weight less than 2 kg at birth or are born for the mother who are hepatitis surface antigen negative, the first dose of hepatitis B vaccine is postponed until hospital discharge or 30 days of age, whichever is earlier. For the babies with hepatitis, the mother has hepatitis surface antigen positive or unknown, we will give at birth 1 dose, and it will not be calculated in the vaccination schedule. Second is influenza vaccine. For all infants, whether they are preterm or term infant, 2 intramuscular doses of inactivated influenza vaccine are given at 1 month apart from each other, started from chronological age of 6 months. Also, the family member of infant younger than 6 months of age or any age with bronchopulmonary dysplasia should be immunized with influenza vaccine. Third vaccine is the RSV vaccine. The prophylactic administration of belvizumab have been shown to prevent severe respiratory syncytial virus in high-risk infant. This includes all extremely preterm infant born at more mature infant, gestational age more than 28 with bronchopulmonary dysplasia, congenital heart disease with cardiovascular compromise, and significant airway abnormality or neuromuscular disorder. As regards the pertussis, all adults older than 19 years of age should receive a single dose of combined tetanus toxoid, reduced diphtheria, toxoid, and acellular pertussis vaccine if they have not already received it, especially if they are close contact with an NF. Last thing, the rotavirus, initial vaccination of preterm infant following discharge from the hospital if they are clinically stable and at least 6 weeks but fewer than 15 weeks of age. Then we will go to the formal clinical assessment. During the first 2 years of life, the formal clinical assessment for neurodevelopmental impairment include all the following. Detailed neurologic examination focused on identifying motor defect, visual assessment, hearing assessment, and standardized test for cognitive and motor function, language, social development, and behavior. Neurodevelopmental assessment, the formal assessment will be started at 4 months of age, corrected by assessing growth and nutrition need, detect severe neurological abnormalities that may require intervention, and at 8 to 12 months, evaluate for early signs suggestive of cerebral palsy and perform initial formal neurodevelopmental assessment with a standardized tool, which will be repeated also at 18 to 24 months. Developmental screening. Assessment of developmental milestone should be done according to the corrected age. The milestone should be assessed in 4 domain: growth motor, fine motor, language, and personal and social. Based on the date of achievement milestone, the developmental age can be calculated. Early identification of development problem should lead to further developmental and medical evaluation and treatment, including early developmental intervention. Common available screening tests, there are Trivandrum developmental screening test and Denver developmental screening test 2. Here, a demonstration for the Trivandrum developmental screening test, and it is very easy test, which is have 17 items taken from Bailey scale of infant development. The test can be used for children from 0 to 2 years. Just place the scale against age line, and the child should pass the item on the left of the age line. This is the Denver developmental screening test 2. We will go now for the developmental assessment. After screening, which is done in every well baby visit, we will do the developmental assessment. The formal developmental assessment will be done at 8 months corrected age using the Bailey scale of infant development. The Bailey scale includes evaluation of cognitive, language, motor, and social and adaptive behavior. The first year of life, motor scale are heavily weighted. However, by the second year, cognitive, language, and behavior may better assessed. Formal developmental assessment use the Bailey scale is repeated also at 18 to 24 months corrected age, along with neurological examination. Now we will go for the neurological assessment. The evaluation of the muscle tone is an integrated part of the neurological examination. As we know from the 28 to 40 weeks gestation, the acquisition of the muscle tone and the motor function spread from lower extremities towards the head, caudalocephalic. After the full term, the process is reversed. So the relaxation and the motor control proceed downward from the next 12 to 18 months. So the upper limb begin to relax and acquire the scales before the lower limb. Here, a demonstration for the how to detect the hypertonia in the lower limb and upper limb by using the adductor obliqual dorsiflexion in the lower limb and the scarf sign in the upper limb. For example, at 4 to 6 months, the popliteal angle must be from 90 to 120, and the scarf sign, the elbow must cross the midline. Also here, demonstration how we will use this tool to check the popliteal angle and the adductor angle. Definition of hypertonia in lower limb by restriction of the adductor angle to less than the age-specific norms, scissoring, tight tendon Achilles, restriction of angle dorsiflexion on the extension of knee. In the upper limb, by the scarf sign, when the elbow not cross the midline at age of 1 year corrected. While the hypertonia of the neck, by increasing the gap between the nape and the table in supine position. What is the abnormalities we will get in the neurological examination or the neurological assessment? Brisk reflexes with hypertonia, brisk reflexes with hypotonia, definitely and consistently elected asymmetrical sign, persistent abnormal posture or abnormal movement. Third thing, now we will go to the hearing assessment. The risk of hearing impairment is 7 times higher among infants admitted to the NICU compared with healthy term neonate. So the Joint Committee on Infant Hearing recommends automated ABR as the initial screening test for hearing for infant during birth hospitalization. And regardless of previous hearing screening outcome, all the infant with or without risk factor should receive ongoing surveillance of communicative development beginning at 2 months of age during well-child visit. The assessment of vision. The very low birth weight infant, especially lower than 1.5 kg, are at increased risk of ophthalmologic abnormalities, including ROB. For all very low birth weight survivors, examination by ophthalmologist, which is expert to evaluate the infant and the children at 9 to 12 months and at 2 to 3 years of age is suggested. Psychological issue and family support. Bringing home NICU graduated be very difficult for the parent because of social, financial, and psychological stress. The incidence of parental depression and anxiety is high both during their infant NICU stay and especially in the month after discharge. So the clinician must be checking for this issue with every post-discharge visit and for early intervention to avoid more complication. NICU graduated are at risk for vulnerable child syndrome like overprotection and Such behavior from parent can lead to conflict within the family as other sibling and spouses may feel neglect. Clinician should monitor for this situation and help reduce its occurrence by providing parent with frequent reassurance and counseling as needed. Neurodevelopmental impairment defined as cognitive function, cognitive delay. The cognitive delay defined by score of less than 70 for severe and less than 85 for moderate on cognitive scale of Pillay scale. The moderate to severe cerebral palsy defined as a score of more than 2 on the gross motor function classification system, and the bilateral hearing defect required amplification, severe visual impairment. So there is need for early intervention program. The early intervention program appeared to be effective at improving neurodevelopment in preterm infants through early childhood. Children less than 3 years with suspected or confirmed developmental behavior problem should be referred to the early childhood intervention program. Can we predict the outcome by neuroimaging? Using of ultrasound is frequently and routinely in the routinely performed for preterm infant with gestation less than 32 weeks, typically within the first few days or weeks of life. Also, the patient with neonatal cranial ultrasound abnormalities compared with those with normal studies are more likely to have long-term neurodevelopmental impairment. Approximately 1/4 of the extremely preterm infant with normal ultrasound may still have cognitive and psychomotor delay.
We have 5 minutes, Dr. Rami.
Okay. The MRI and at term gestation. MRI term gestation may be useful in prediction long-term neurodevelopmental outcome for preterm infant and risk for neurodevelopmental impairment. We will do the MRI for all infants with gestational age less than 28 weeks to follow up abnormal cranial ultrasound result. If the infant has concern finding on neurologic examination, if a congenital or metabolic defect is suspected, if infant loses previously achieved neurodevelopmental milestones. The medical care of a special condition. There is a long list of the medical condition must be cared by the clinician for the high-risk preterm post-discharge. Most of them are respiratory, like the apnea of prematurity, bronchopulmonary dysplasia, sudden infant death syndrome, gastroesophageal reflux, anemia, bone health, and orthopedic and surgical disorder. The NICU graduated, including both term and preterm infant, are increased risk for the readmission. But the preterm, especially with gestational age less than 28, have the most common rate of readmission. The most common cause of rehospitalization, including infection, respiratory problem, feeding difficulties with inadequate growth, and the surgical issue. The parent should be made aware of increased potential readmission for their preterm infant. In the next slides, there is some advices for the parents or the family for early stimulation of their baby to achieve good development. From 0 to 2 months, we encourage the babies to maintain eye-to-eye contact and provide different sound to child to rattle, pill, squeezing to a toy, and keep the baby in a well-lighted room. From 2 to 4 months, try to hold the baby at the shoulder and give sound-producing toys, and for visual, bring object about 30 centimeters above the crib. From 4 to 6 months, try to set the baby on the mother lap and ask her to gently bounce her knees, singing song. From 6 to 8 months, make the child sit along as possible and give support to his pelvis and give him pieces of paper to tear. The take-home message: appropriate and comprehensive follow-up program is essential for high-risk infant, not only to ensure intact survival and optimal growth, but also to optimal quality of life for this infant. The initial outpatient visit is scheduled within 48 to 72 hours after hospital discharge. Subsequent visits focus on routine primary care, including growth, nutrition, and immunization. Follow-up visit closely monitor for the patient to growth. If the growth is inappropriate, the infant nutrition is evaluated and the corrected measures are initiated. For all infants, regardless of the gestational age, we recommend administration childhood vaccine based upon his or her chronological age. Screening for hearing, vision, neurodevelopmental problem is necessary because of high rate of abnormalities. The clinician should be familiar with the more common medical problem that may present in the NICU graduated patient. And lastly, the NICU graduation are at risk of hospital readmission. The rate of rehospitalization increase with decreased gestational age. Thank you.
Thank you so much, Dr. Rami, for your long lecture. Alhamdulillah that we have time for it. But it was great presentation. Thank you so much. We don't have any questions, so we'll move to our next speaker. You can stop sharing.
Assalamu alaikum.
Our next speaker will be Dr. Latifa Al-Mahmoud. Dr. Latifa is a consultant neonatologist in King Saud Medical City, Al-Shimisi Hospital. She is the previous head of the neonatal unit. Al-Shimisi Hospital is a very famous maternity hospital here in Riyadh, and it has the most busy NICU unit. Dr. Latifa will speak with us about prevention of IVH. I wish that we can really prevent IVH. Okay, Dr. Latifa, you can start sharing.
Assalamu alaikum. Assalamu alaikum. دكتور سامعين الصوت؟
I cannot hear you, Dr. Latifa.
I don't know.
Now it's okay.
سامعني الحين؟
أيوة, now it's okay. بس.
السلام عليكم.
وعليكم السلام ورحمة الله وبركاته.
Yeah, thank you, Dr. Nabil, for your invitation. I will talk about the intraventricular hemorrhage, which is a common complications of prematurity, and we are seeing this complication in our ICU frequently. The incidence of IVH is about 25% among very low birth weight infants. And the data from Vermont Oxford Network showed that infants who weigh less than 750 grams have tenfold increased risk of developing grade 3 to 4 IVH. And 50 to 75% of the survivors, they will have a cognitive impairment and cerebral palsy and hydrocephalus. 50% of the IVH occur in the first 24 hours of life, and 99.5% within the 7 days of life, and 20 to 40% of IVH progress over 3 to 5 days. This is the known classification of the our grading of the IVH. As we know that grade 1 is unilateral unilateral or bilateral germinal matrix hemorrhage. Grade 2 IVH without ventricular dilatation, and grade 3 with ventricular dilatation, and in grade 4 we have extension of the bleeding into the adjacent parenchyma. This is according to the Papil criteria. And for Volpe criteria, germinal matrix hemorrhage with no IVH or IVH occupying less than 10% is grade 1. IVH occupying 10 to 50% of the ventricular area is grade 2, and grade 3 IVH occupying 50% of the ventricular area, and with or without preventricular ecodynasties. And in grade 4, there is preventricular venous hemorrhagic infarction, cystic preventricular leukomalacia. And there are vascular and extravascular factors contributing to the incidence of the intraventricular hemorrhage. The first is the vascular factors, and as we know, germinal matrix is located in the ganglionic eminence of the brain in the caudate nucleus, and the thickness and density of the germinal matrix vasculatures is more than the other area of the brain, more than other areas in the brain, and this thickness and density decrease after 24 weeks of gestational age, and disappear at 36 to 37 gestational age as the fetus get mature. There is a significant bleed in highly vascular germinal matrix. If there is a highly significant bleed in highly vascular germinal matrix, this will break the ependyma to involve and extend to the lateral cerebral ventricles, causing intraventricular hemorrhage. The blood-brain barrier is associated with the blood-brain barrier in the germinal matrix vasculatures is distinct from the other remaining areas in the brain because it is the pericyte is reduced, and also fibronectin in basal lamina, and glial fibrillary acidic protein, which is GFAP in astrocyte in feets. All these are reduced in the blood-brain barrier in germinal matrix vasculatures. This lead to change or weakness in the structural integrity of germinal matrix vasculatures. The pericyte has a role which is essential in the development of blood-brain barrier, as it is responsible about early angiogenesis and extracellular matrix production, endothelial maturation. Decrease in the pericytes in germinal matrix will lead to decrease in the level of transforming growth factor beta and predisposition to hemorrhage. The fibronectin is a high molecular weight glycoprotein, and if it is deficient in the germinal matrix basement membrane. And fibronectin polymerize to provide structural integrity to blood vessels and is dependent on transferring growth factor beta for its upregulation. So it's also deficient. Astrocytes also provide vascular integrity by cheating the predominance of the blood-brain barrier with glial fibrillary acidic protein rich extension in the infants, and decrease in this GFAP will lead to brain barrier fragility and more susceptible to hemorrhage. Extravascular factors, germinal matrix itself is a gelatinous region. This make it poor support for the small vessels that cross through the germinal matrix. Also, this area contains an excessive amount of fibrinolytic activity, which lead to frequent extension of the hemorrhage. Other factors, which is intravascular factors, which embed cerebral autoregulation, fluctuation of cerebral blood flow, and increased cerebral blood flow due to hypercarbia, excess volume expansion, increased cerebral venous pressure with pneumothorax, asphyxia, heart failure, hypotension, and reperfusion. Coagulation abnormalities is also playing a role in the pathogenesis of IVH. The risk factors like suctioning and frequent handling of the baby, hypercarbia, hypoxia, acidosis, asynchrony of the ventilation, severe RDS, and BDA, rapid infusion of sodium bicarb, pneumothorax, and high ventilator settings. All this fluctuates cerebral blood flow and disturb cerebral blood flow, increase the incidence of IVH. Again, through another mechanism, pneumothorax, high ventilatory pressure, and prolonged labor also disturb the cerebral blood flow by increasing cerebral venous pressure. And hypotension, hypertension, sepsis, dehydration also disturb cerebral blood flow by abnormal blood pressure. Prematurity itself and being extreme low birth weight, sepsis, and other reasons also cause pressure passive circulation and impair the protective effect of autoregulation and disturb the cerebral blood flow, increase the susceptibility to IVH. Hypoxic ischemic insult and sepsis also cause inflammatory injury to blood-brain barrier. Thrombocytopenia, DIC also cause hemostatic failure due to platelets and coagulation disturbance. The fluctuating blood pressure in a pressure passive circulation, this this is because of that the autoregulation itself is an important neuroprotective mechanism for the babies, allowing the infants to maintain constant cerebral blood flow and perfusion during fluctuation of systemic blood pressure and fluctuation of blood volume. In sick preterm infants, this protective mechanism is lost, and this will lead to pressure passive circulation, and any change in systemic blood pressure will fluctuate the cerebral blood pressure and subsequently lead to change in cerebral blood flow and volume and pressure. Any disturbance in cerebral blood flow will lead to IVH. Hypoperfusion will lead to ischemia and germinal matrix cell injury directly, and reperfusion again will lead to rupture and hemorrhage. Arterial CO2 tension. BCO2 has a pronounced effect on cerebral blood flow, and in the first 24 hours after birth, every kilopascal of increments in the BCO2 will increase the cerebral blood flow by 10%. So PCO2 more than 60 millimercury increase risk of IVH by twofold, and reduction also or reduced BCO2 less than 39 millimercury increase the risk of IVH by 2.5-fold. Usually we are practicing in our unit the permissive hypercapnia, and it is common practice in most NICUs. And the clinicians should be aware about the associated risk of IVH with hypercapnia. They noticed that infants with PCO2 maintained within the range of 45 to 55 millimercury demonstrate no increased risk of IVH compared with normal capnic infants. So this is safe safe values. Decrease in hemoglobin concentration. The preterm infants with anemia have increased risk of IVH. The anemia is associated with increasing in cerebral blood flow, and every one millimole reduction in hemoglobin will lead to increase in 12% in cerebral blood flow. The brain is trying to maintain effective delivery of oxygen to cerebral cells. Implementation of delayed cord clamping policy will decrease the initial anemia, and it provides a protective mechanism. Pneumothorax is associated with increased risk of IVH, as it is increasing the arterial blood pressure significantly, and increase also the intrathoracic pressure will lead to change in venous pressure. So it contributes again to the intraventricular hemorrhage. Here we are summarizing the pathogenesis. Ventilatory instability and hypocapnia, patent ductus arteriosus with left to right shunt, decrease intravascular volume, anemia, myocardial dysfunction and immaturity. All these will decrease cardiac output, plus the ventilatory instability. They will all act to decrease cerebral perfusion and cerebral ischemia with injury of the germinal matrix. Usually the clinician will interfere during this time, trying to treat with systemic hypotension with vasoconstrictor and ventilatory change with a fluctuation of CO2, and treatment of BDA with indomethacin. This will lead to reperfusion injury, again with increase in cerebral perfusion, increased systolic and mean arterial blood pressure. Hypercapnia will lead to cerebral vasodilatation. All this will subsequently lead to rupture of germinal matrix and IVH. Here we are summarizing again the risk factors, or classify the risk factors to prenatal, perinatal, and postnatal. Prenatal, like in vitro fertilization, poor antenatal care, lack of prenatal corticosteroid administration, chorioamnionitis, and multiple gestation, low gestational age, IVH, fetal distress, vaginal delivery, extreme prematurity, low Apgar score, need for resuscitation, intubation, ventilation, Postnatal factors like neonatal transport and medication like vasoconstrictor, hydrocortisone, anemia, blood transfusion, sepsis, BDA, respiratory distress, and hypotension, hyponatremia, and other factors. The clinical signs of IVH can be presented silent, as the extreme preterm have large extracerebral space, and they will take long time until they have a full anterior fontanelle bulging. So we will just discover it with the head ultrasound, or catastrophic presentation with rapid neurological deterioration over a period of minutes to hours, with bradycardia, apnea, pallor, and reduction of hematocrit, seizures, and other symptoms. Saltatory symptoms appears over a period of hours and days, with the decrease in alertness, motor activity, hypotonia, abnormal eye movement, and respiratory difficulties, increase in head circumference, and fullness of anterior fontanelle, with increase in intracranial pressure, apnea, bradycardia, lethargy, and decreased activity. Usually, the diagnosis by cranial ultrasound, it's the cornerstone for diagnosis. Sensitivity is 96% and specificity is 94%. It is readily available, portable, reliable, cost-effective, non-invasive, and radiation-free, and need no special preparation, and performed in incubator and with less manipulation. The findings are operator dependent, and subtle lesion may be missed with an non-expert radiologist. The abnormality should be correlated on both coronal and parasagittal views, and the finding on the left and right side should be graded separately. Location, size, and extent of lesion should be also documented, and the hemorrhage, the IVH, can be progressive, and the grade may change from 1 to 2 or 3 to 4, so screening needed multiple times. For screening guidelines, the Canadian recommend routine ultrasound for all neonates born less than 32 weeks between 4 and 7 days of life, or aerial depending on clinical state, and a newborn more than 32 weeks and less than 37 weeks if there is additional risk factors. They will repeat the image at 4 to 6 weeks of life for only neonate born at less than 32 weeks, and for those more than 32 and less than 37, if the first cranial ultrasound was abnormal, the image will be repeated. The American Academy recommend for all preterm infants born less than 30 weeks or more than 30 weeks, if there is significant factors, the initial ultrasound within the first 7 to 10 days, and the subsequent scan at 4 to 6 weeks of life, and at term corrected age or prior to discharge. The serial ultrasound for infants with abnormal ultrasound according to the clinical state. MRI superior to ultrasound detecting white matter abnormalities and cystic lesion, but it is difficult for a newborn and requiring the neonate to be sedated and unsuitable for unstable patients. It is recommended for grade 3 to 4 IVH, post-hemorrhagic ventricular dilatation, and for grade 3 and 4 preventricular leukomalacia, and when clinical risk for white matter infarction, and for prenatal reassurance. Prevention of IVH, since IVH is primarily linked to an increased vascular fragility and disturbance in cerebral blood flow, strategy are directed to strengthen the germinal matrix microvasculatures and to stabilize cerebral blood flow. First of all is preventing the preterm birth, and the measures that target prevention of preterm birth is the most important strategy for minimizing the occurrence of IVH. Preterm birth can be delayed unless medically indicated by antenatal progesterone supplementation, cervical cerclage for cervical incompetence, tocolytics for preterm labor, and avoidance of tobacco smoking during pregnancy. Prenatal corticosteroids, WHO strongly recommends prenatal corticosteroid use for all women at 24 to 34 weeks gestation for whom preterm birth is imminent. Short course of prenatal corticosteroid will stabilize the germinal matrix vasculatures through suppression of vascular endothelial growth factors and transforming growth factor beta levels. It decreases incidence of IVH and also decrease significantly white matter injury. May be linked to the reduction in the incidence of severe RDS and necrotizing enterocolitis. Magnesium sulfate, it is used for the prevention and management of eclampsia, and the meta-analysis of six randomized control trials and 5 cohort study conducted between 1995 and 2004 provided evidence that magnesium sulfate administration to the women at high risk of preterm labor provides significant neuroprotection against moderate to severe cerebral palsy without causing adverse effect on the infants. So it is its effect on the cerebral palsy, but not the IVH. WHO and American College of Obstetric and Gynecology currently recommend the use of magnesium sulfate for women at risk of imminent preterm birth before 32 weeks of gestation for the prevention of cerebral palsy during infancy and childhood. The systemic review and meta-analysis showed that magnesium sulfate had a protective effect on IVH in premature infant, and this effect was not statistically significant. Delivery at tertiary center and avoid neonatal transport, preterm transport. High-risk preterm delivery should be conducted in a tertiary center, and the evidence from large retrospective analysis of 67,596 very low birth weight preterm babies found a correlation between intra-hospital transport and increase the incidence of and severity of IVH. Maybe it is related to that increase of head and torso vibrations during neonatal transport. Delayed cord clamping, implementation of delayed cord clamping lead to increase in hematocrit and severe vena cava blood flow, right ventricle output, and right ventricular stroke volume and blood pressure. It's also reduced delivery room resuscitation and decrease also earlier blood transfusion and IVH, NIC, and mortality. The optimal duration for cord clamping remains controversial. The American College of Obstetric and Gynecology, American Academy of Pediatrics recommend at least 30 to 60 second delay to clamp cord for preterm and term neonates not requiring suspension at birth. WHO strongly recommends at 60 to 180 second delay. Postnatal indomethacin or ibuprofen, the evidence for their use is controversial. The evidence for the use to prevent IVH is controversial. A multi-center double-blind randomized control trial found that prophylactic ibuprofen within the first 6 hours of birth was ineffective against preventing grade 2 to 4 IVH. So both indomethacin and ibuprofen are not recommended for prevention of germinal matrix IVH use, but still it can be used for BDA treatment. A midline head positioning. Midline head positioning is thought to optimize cerebral venous drainage through the internal jugular veins, which are the major outflow path for cranial blood. And head rotation to either side may result in ipsilateral occlusion or obstruction of the jugular venous drainage system, which will lead to or result in large alteration in blood flow velocity in the superior sagittal sinus, and subsequently lead to increase in cerebral blood volume and intracranial pressure, and lead to intraventricular hemorrhage. The systemic review and meta-analysis reported inconclusive evidence that head positioning prevent occurrence and extension of germinal matrix intraventricular hemorrhage. Prevention of necrotizing enterocolitis. NEC is associated with persistently lower cerebral tissue oxygenation, and breast milk probiotic pyophene lactoferrin increase the risk of NEC, and this may help in improving the cerebral tissue oxygenation. Ethamsalate is promote platelets adhesion and increase capillary basement membrane stability through hyaluronic acid polymerization. And the Cochrane database systemic review of 1,410 preterm infants from 7 trials showed that the infants less than 35 weeks of gestation with ethamsalate are significantly less likely to develop germinal matrix IVH compared to control. The review did not show a significant difference in neonatal mortality or neurodevelopmental outcome at 2 years between infants treated with ethamsalate and controls. So the routine use of the ethamsalate for prevention of IVH in preterm infant is not recommended yet. Phenobarbitone and decrease fluctuation in systemic blood pressure, and also protect the brain after hypoxia and ischemia. Meta-analysis showed that phenobarbitone does not decrease the risk of all IVH, severe IVH, post-hemorrhagic ventricular dilatation, severe neurodevelopmental impairment, or in hospital death. But they noticed also that it increased use of mechanical ventilation in the phenobarbitone treated group. So postnatal phenobarbitone cannot be recommended for the prevention of IVH. Recombinant human erythropoietin. Early IV administration of high dose of erythropoietin to the preterm infants less than 32 weeks is safe, but it was found that it is significantly increased the hematocrit and reticulocyte and white blood counts, but no difference in the development of retinopathy of prematurity, IVH, sepsis, NEC, and chronic lung disease and mortality. Near-infrared spectroscopy monitoring for cerebral oxygenation. Systemic arterial oxygenation, which we are monitoring, it does not always reflect the cerebral oxygenation. So cerebral oxygen saturation monitoring using near-infrared spectroscopy is recommended. And in a recent multi-center study of 103 neonates with gestational age 26 week and birth weight less than 1,250 grams, they found that a clinically significant associated between low cerebral oxygen saturation using near-infrared spectroscopy in the first 96 hours of life and abnormal cranial ultrasound findings. So cerebral oximetry can be used to monitor high-risk infants such that timely intervention are taken to improve cerebral oxygenation. Vitamin E is an oxidant that scavenges free radicals. They found that it is decreasing the risk of germinal matrix IVH and increase the risk of sepsis in preterm infants. And in very low birth weight infants, decrease the risk of ROB, but also increase the risk of sepsis. It was all the studies, so maybe the survival at that time is still low for preterm babies. So more research is needed before recommendation can be made. This is the outcome and the prognosis of IVH. We can see that grade 1 has 5% in mortality and progressive ventricular dilatation and neurological sequelae, compared to grade 4, which is having high mortality rate 50% and progressive ventricular dilatation 80%, and neurosurgical sequelae is 90%. The management of post-hemorrhagic ventricular dilatation is a challenge to clinician, and no standardized protocols for the treatment of post-hemorrhagic ventricular dilatation. And usually the aim of management is to improve a neurodevelopmental outcome by preventing secondary damage and avoiding the need for permanent shunt and complication like obstruction and infection. And the management of IVH and post-hemorrhagic hydrocephalus include aggressive removal of intraventricular blood and its breakdown products, iron and free radicals, and the appropriate treatment for raised intracranial pressure due to post-hemorrhagic ventricular dilatation. How and when best treatment to optimize the neurodevelopmental is still controversial. Usually there is a non-surgical treatment, which is medical treatment, and it is proved that it is inefficient and no significant benefit from use. It will not benefit the survival or reduce the need for shunt. And repeated tabbing of CSF, and this is also found in Cochrane review that it have no beneficial effect. There is no beneficial effect of repeated LB and do not decrease the need for permanent shunt or neurological disability. And it's usually difficult to perform LB in clinically unstable infants. And its effectiveness also decreased by repeated attempts. Surgical treatment, either with the drift trial, drainage and irrigation fibrinolytic therapy, and randomized control study provide direct evidence in favor of removal of blood from the ventricles to improve the outcome. The aim was to decrease mortality and cognitive, motor, and sensory disability, but it was suspended due to a risk of secondary bleeding. The short outcome, there is no decrease in shunt or surgery or death, but the long-term follow-up, there was significant decrease in severe cognitive disability or death at 2 years from 71 to 54%. And the benefit was maintained at 10 years follow-up. It's not recommended for the treatment of post-hemorrhagic hydrocephalus because of risk of secondary hemorrhage. The other part of treatment is a shunt, either ventricular reservoir or ventricular subgaleal shunt, and or permanent ventricular peritoneal or ventricular atrial shunt. With their complication, which is over drainage, shunt blockage, and infection, and prolonged hospitalization. I will not go through the management of hydrocephalus. I will stop here, and I will say thank you for listening, and that's it.
Thank you so much, Dr. Latifa, for your nice presentation. Actually, it was very informative. If someone has any question, we can take. Till now, there is no. So, okay, thank you, Dr. Latifa. You can stop sharing, please. Our next speaker will be Dr. Fahd Mubarak Al-Habshan. He is the head of the Pediatric Cardiology Division in King Abdulaziz Cardiac Center in King Abdulaziz Medical City, the National Guard. Dr. Fahd is an Associate Professor of Cardiac Sciences in King Saud bin Abdulaziz University for Health Science. Dr. Fahd will give us a presentation about cardiac involvement in COVID with MIC. Dr. Fahd, you are welcome. Can start sharing.
Assalamu alaikum. Good evening, everybody, and thank you very much, Dr. Nabil, for this introduction. And really, congratulations for putting up this nice conference. It's a great effort. And what's more beautiful about it is the continuous and perseverance year after year for producing this nice conference.
Thanks a lot, Dr. Fadu. I'm happy to have you with us. Thank you.
So now, can you share? Can you see my slide?
Yes.
Oh, okay.
You can best make full screen and it's okay.
It is a full screen. Can you see it as full screen?
Now, yes.
Yes. Okay. So as you said, I'm working at King Abdulaziz Medical City. This is just pictures for our beautiful cardiac center. People are welcome to visit. And I was given the subject to speak about this MIS-C, or the multi-system inflammatory syndrome that can happen in children and young adults after COVID-19 infection. This is a rare sequelae, but we have seen it. We have seen many cases. I remember a young patient that was admitted in PICU in the Saudi German hospital she was about 9-year-old girl, and she had severely depressed ventricular function. And then she was diagnosed as having this multi-system inflammatory syndrome. This syndrome is distinct from other similar conditions like the Kawasaki disease, toxic shock syndrome, the HLH, or the macrophage activation syndrome. This syndrome specifically has multi-organ involvement, where the patient presents with fever with high inflammatory markers after COVID-19 infection. And typically these patients, they start by fever, followed by gastrointestinal symptoms in the form of abdominal pain, vomiting, sometimes diarrhea, but mainly the abdominal pain and the cramps that typically happens. Then after that, they get very quick cardiovascular collapse. These patients collapse quickly and they come to the emergency room, usually in shock. Some of them may have the dermatological or mucocutaneous features or lymphadenopathy similar to the Kawasaki disease. Some of them may have other systems involved like respiratory, musculoskeletal, neurological, but many of them, unfortunately, if they are missed, they may go into shock. And if you don't treat them properly, these patients are at risk of death. There are three main phenotypes for this disease. There is the MIS-C shock phenotype, where the patient presents critically ill and hypotensive. And usually there is an hyperinflammatory process that happens, like multi-systemic inflammation. Typically, these patients, they have hypoalbuminemia and hyponatremia. And if you check their cardiac enzymes, the troponin will be very high. And usually they have ECG abnormalities with STT wave changes mimicking the presentation of myocarditis, where they have sometimes ST depression and T-wave inversion with tachycardia and changes in the QRS voltage. The other phenotype is what's called the MIS-C Kawasaki phenotype. And these patients have very similar picture to the Kawasaki disease, where they have the mucocutaneous changes, the skin changes, in addition to the fever and the other features of presentation. And usually this is in the more older group of patients. But these patients have different ethnicity compared to the Kawasaki disease, and they have more GI symptoms than what we see in Kawasaki disease. And usually they have more severe cardiac involvement, because usually in Kawasaki disease, mainly it is the coronaries that involved. In MIS-C, the serious part is the myocarditis and the cardiac inflammation with the cardiac dysfunction. The other phenotype is the MIS-C with fever and inflammation, where the patient will get only fever and some markers of inflammation, but usually they are well and they don't go into shock, and they don't have any clinical features of other disease, like any of the features of Kawasaki disease. MIS-C typically is a disease of young people. You don't see it in older patients who got COVID. And majority of the patients that were admitted in our hospital in National Guard were in the typical age group that is described by the CDC, which is 20 years or younger. And typically these patients, they present with continuous fever for more than 24 hours. Sometimes the fever may subside at the time of presentation, but there will be a history of fever and exposure to COVID-19. And typically these patients, they have lab evidence of significant inflammation. So their inflammatory markers are significantly elevated. You will find high ESR, high CRP, the procalcitonin might be elevated. So it is enough for the diagnosis to have one of these inflammatory markers to be elevated to call it an inflammatory process. The other thing is the evidence of clinically severe illness that require hospitalization, where we get more than two systems involved. Typically, the cardiac and the gastrointestinal system in majority of these patients. But some of these patients may present with cardiac and respiratory symptoms, or sometimes other like hematological symptoms or something like that. And these patients, they don't have any other clear explanation for this sudden severe illness. And typically they will have a positive COVID-19 by PCR, or sometimes COVID-19 has passed through, but they get the antibodies positive for the COVID-19 or history of exposure in the first few weeks. These patients typically, they develop cardiac dysfunction, which is the main problem they have with MESI, that they get a picture of myocarditis and depressed ventricular function. And if they are not picked up, they may go into shock. Typically, they will have abnormal ECG with abnormal STT wave segment and abnormal QRS complexes. And we may see, or we have seen in many of them, coronary artery dilatation similar to the Kawasaki disease. Majority of them are milder than Kawasaki disease, but presence of aneurysm also has been reported in this illness. The myocardial injury can happen in any of the three phenotypes. So even if you get the minor phenotype, the phenotype of fever and just high inflammatory markers, don't take it lightly that the patient does not have any major system involved. Patients should be admitted and observed because the deterioration usually is very quick. These patients, the main issue, as we said, is the myocarditis, and usually it is the main contributor to the mortality of these patients if it is not picked up. And the diagnosis for this is by echocardiography, where we find a severely dilated ventricle with severely depressed function. There are reports of cardiac MRI that was performed in older patients and showed the evidence of myocarditis. And there are reports of biopsy diagnosis of myocarditis in patients who had a vague or gray area of diagnosis. The electrical changes that we see are typically the STT wave changes, but these patients also typically they can have arrhythmia, and all kind of arrhythmia has been described. First degree block, complete heart block, ventricular tachycardia, supraventricular tachycardia, ventricular fibrillation. And typically these patients, the higher the troponin is, the more malignant type of arrhythmia you will see. So you need to check the troponin and see if it is high, then watch for arrhythmia. That's why these patients should be on cardiac monitor all the time. They should not be admitted to a general ward where they can be left alone overnight for 4-hourly vital signs or something like that. The other important finding is the coronary changes, and they will develop coronary artery dilatation. It has been described in about 20% of these patients, while in Kawasaki, it's been described in 30 to 40%. And many of these patients, they just have dilatation, mild dilatation, unlike the aneurysms in Kawasaki. And usually the resolution is quicker in this disease than in Kawasaki. So this algorithm shows their presentation and how it happens. So the first thing is the exposure to the COVID-19. And then with that, there is an inflammatory process that develops, and the symptoms, the typical symptoms that we will see is the presence of fever in almost all of the patients, followed by the GI symptoms in about 60% of the patients. And then some patients may present with picture like Kawasaki with rash and conjunctivitis, and they may have, minority of them may have extremity changes as well. And then if you look at the lab work, typically they have high inflammatory markers like CRP, ESR, and their white cell count might be elevated also. and the troponin might be elevated, especially in patients with myocarditis. The coronary changes, you see, if you can look at this small picture, the upper picture, you see this is a coronary artery, this is the aorta, and this is the left coronary artery, and this is the right coronary artery, and both are dilated. Normally in children, the coronary arteries are difficult to see. If you see the coronary arteries clear like this, usually they are abnormal. In few cases, aneurysm can happen, like in this patient, you see this is an aneurysm in the right coronary artery. The main problem is usually ventricular dilatation. You see the left ventricle is dilated and the ventricular function becomes depressed. Some patients may get valvular regurgitation with a picture of valvulitis. Some patients may develop effusion, and majority of them will have ECG changes, STT wave segment, and arrhythmia. These patients, how can we approach them? There is like a stepwise diagnostic approach, which was described by the American College of Rheumatology, where if you get a child or younger adult with COVID-19 and persistent fever, and then you have at least 2 suggestive clinical features, which is the rash, gastrointestinal symptom, or if they have peripheral changes, then you look at this patient and you see if he has these changes, then if there is another explanation for this disease, then you stop. If there is no other explanation, then consider that this patient is having MESI and start the investigation. If the patient has clear other diagnosis, then still investigate for MESI, and if the patient has increased inflammatory markers, then he should be admitted and he should be considered under observation. If the patient has more than 2 systems involved, then detailed investigation by including other system examinations, especially the cardiac, which is the ECG and echo mainly, is important. So the investigations, they divide it into what's called Tier 1 and Tier 2. Tier 1 is mainly the inflammatory markers, plus one of the either a CBC change or chemistry change. Then the Tier 2 are the cardiac enzymes, the BNP, the ECG, and the echo, which are mainly related to the cardiac changes because these are the main cause of morbidity that is seen. So if we have a child with persistent fever in an endemic area of COVID-19, consider it as MESI until proven otherwise. Don't take it lightly. If a child presents with shock in an endemic area with COVID-19, then it is MESI, and the patient should be treated as MESI even without all the detailed investigation. So this was the diagnostic approach. And then in the investigations, when should we do the ECG? It should be done within 24 to 48 hours from the admission, and then during the follow-up visits as well. These patients, when they are admitted, as I mentioned, they should not be in the general ward. They should be on continuous telemetry or continuous ECG monitoring, because ECG changes can happen at any time. The Holter monitor can help if you don't have a continuous monitoring, and it can help also during the follow-up. The echocardiography should be done at the time of the diagnosis, and mainly 2 things. We look at the LV function and we look at the coronary changes. And then if it is normal, we should repeat it in 1 to 2 weeks, and then in 4 to 6 weeks. But if it is abnormal, we may do it more frequent. Some patients, if we are not sure about the coronary changes, we may do cardiac CT to look at evidence of coronary dilatation or aneurysm. For the management part, these patients, they should be stabilized first to be managed. If they present in shock, you should start with the ABC, the airway, breathing, and cardiac. But the most important thing is to remember that you manage as cardiogenic shock patient. Even if the patient is not hypotensive, don't give large boluses of fluids, especially if you have a cardiac dysfunction. If you did the echo in ER, you suspect MESI and you request echo and the cardiac function is abnormal, then you should not give large bolus. And the main treatment is IVIG. And IVIG, the treatment, the dose is 2 grams per kilo per day. But in these patients, if there is cardiac dysfunction, it should be much slower, over 2 days, giving 1 gram each day, 1 gram per kilo each day. And the treatment should be with a multidisciplinary team, including the cardiologist, the rheumatologist, the ICU team, hematology, and so on. The most important part in the treatment, as I mentioned, is the immune modulation therapy, which is IVIG and steroids. So always we start with the IVIG whenever we suspect MESI, if we have a child with positive COVID and increased inflammatory markers with persistent fever, GI symptoms, we should start IVIG even before getting the echo, similar to what we do with Kawasaki. And then if we do the echo and then the patient has evidence of severe myocarditis, then we can add steroids to that. And both IVIG and steroids showed strong evidence of less chance for ICU admission and shorter duration of hospital stay. Similar to Kawasaki disease, there is refractory Kawasaki. There is also a refractory MESI, where the patient, the definition similar to Kawasaki, if the patient has persistent symptoms after the first dose of IVIG, then this is non-responsive. And in these patients, we don't give second dose. In Kawasaki, we usually give second dose. Here, we don't give second dose. We give high dose steroids. So these patients, this is the algorithm for the treatment. So the most important treatment, as you can see here, whether the patient has a life-threatening or multi-organ involvement or not, both should receive IVIG. If the patient has multi-organ or present in shock because of cardiac involvement, then steroid should be also added to the IVIG. It's either the methylprednisolone continuous 1 to 2 milligram per kilo per day, or the pulse therapy, which is 30 milligram per kilo. And then if the patient did not improve after the first dose, then we can repeat the methylprednisolone or consider high dose anakinra. So it is mainly IVIG as the first line of treatment, then steroids, and then anakinra, which is the recombinant interleukin-1 receptors antagonist. And when we give anakinra or the steroids, we should extend it over 2 to 3 weeks, because there had been cases that are described to have rebound inflammation, where if you give the steroid over shorter duration, like over just few days, the patient may get a rebound inflammation after stopping it. During the treatment, if the patient has cardiac involvement or coronary changes, then the patient should receive antiplatelet treatment by aspirin, or if there is a large aneurysm, more than 10 Z-score or more than 10 millimeter in diameter, then he should be also on warfarin. Usually, majority of our patients, they received aspirin, and usually it is shorter duration, which is about 4 to 6 weeks, because these patients, when we follow them, we get them at the time of diagnosis, then we see them at 2 to 4 weeks, then at 4 to 6 weeks. And usually, unfortunately, majority of these patients, they have complete resolution of their illness by 4 to 6 weeks, unlike the Kawasaki disease, where the coronary dilatation usually lasts for months. And during these visits, we should consider ECG and echo every visit. And then we may consider MRI if the patient has persistent LV dysfunction. And this can be done if that persists more than 6 months. Fortunately, as I mentioned, MESI is characterized by fast recovery. If you catch the patient well and treat the patient well, usually these patients recovered very well. Almost all of the patients I have seen maybe almost like a dozen of patients who had cardiac involvement with COVID, where they come with severely depressed function. Before they go home, before they leave the hospital, usually the function resolves. The cardiac function goes back to normal. And the coronary changes usually resolve by 4 to 6 weeks, unlike the Kawasaki patients. So this is the good part of it. So the most important part of this illness is the recognition. And part of this symposium is to improve the awareness about this in the population of the pediatricians, to catch these patients early, manage them early, and fortunately come up with an excellent prognosis as it should be. Thank you very much for your attention.
Thank you so much, Dr. Fahd, for your great presentation. I hope, inshallah, you will not see much cases of this type.
Hopefully, with the resolution of COVID, but still we may see it from time to time because COVID is still there.
Yes, there is a lot of COVID cases still, but not so severe like before.
Yes.
Okay, anyone has a question he can write? If not, we will go to our next speaker.
Okay, thank you so much, Dr. Nabil.
Thank you, Dr. Fad, for being with us. Thank you. Our next speaker will be Dr. Manam Najjar. We're just waiting for him to join. If he will be late, we'll postpone his lecture and we'll start with Dr. Samira. So just we'll call him and see his situation. Dr. Manal has a little technical problem. He is trying. We'll give him some 2 minutes. If he will not be able to join, we will proceed to Dr. Samira lecture. Okay, so we'll start with Dr. Samira lecture until Dr. Manar will join us. So our next speaker will be Dr. Samira Ghalab, our consultant pediatrician. She will give us a speech about cooling therapy in perinatal asphyxia. You can share your screen.
صوت صح؟ في السكرين. بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله وبركاته. I will speak in this presentation about therapeutic hypothermia in neonates with hypoxic ischemic encephalopathy. I will concentrate in the talk about the procedure itself. I will start with introduction to therapeutic hypothermia. We'll speak about the eligible and the exclusion criteria, the procedure, and how to monitor the patient, the side effects, combination therapy with other neuroprotectives, and then what is after therapeutic hypothermia, or what is the prognosis. Therapeutic hypothermia is a clinical treatment that involves moderately reducing patients' body temperature in order to slow disease progression and to improve health. It is the only proven way of neuroprotection which is applied to children of neonates with hypoxic ischemic encephalopathy who fulfill specific criteria using specific policy. Hypoxic ischemic encephalopathy is a condition of impaired blood gas exchange, or what is meant by hypoperfusion, leading to hypoxemia and the manifestation of neonatal encephalopathy. Hypoxic ischemic encephalopathy is one of the important causes of neonatal encephalopathy in neonates. This is classified according to the severity with the modified Thornett classifications to mild, moderate, and severe encephalopathy, depending on 6 categories, including the level of consciousness, spontaneous activity, posture, tone, primitive reflexes, including the sucking and moro, and autonomic pupillary reflex and respiration. If 3, we need to diagnose the encephalopathy. If we have 3 from these categories, are positive signs for encephalopathy, and can mild or moderate or severe. This is a picture of pathophysiology of hypoxic ischemic encephalopathy, which usually started with the insults, then leading to primary energy failure. Then within 6 to 72 hours, it will start the secondary phase with mitochondrial dysfunction and the release of the free radicals and the occurrence of cell apoptosis in severe form. The window of therapeutic treatment here is the first 6 hours that we can apply the hypothermia or combined with other neuroprotective measures. The aim is to decrease the cerebral metabolism and energy depletion, to decrease or prevent mitochondrial dysfunction, to decrease or prevent the release of free radicals, and to decrease the vascular permeability and edema, and to decrease and prevent the cell apoptosis. So who is the candidate for neonatal encephalopathy, neonatal therapeutic hypothermia? We should have, to start the cooling, we should have at least the main 3 points must be, or 3 criteria must be present. The first one is the gestational age. Gestational age is 36 or more weeks with the age of 6 hours or less. And some centers are using the 34 or 35 weekers with birth weight 1.5 kg, or some using the minimum birth weight 2 kg. The second criteria is the presence of metabolic acidosis or mixed metabolic and respiratory acidosis with a pH of 7.00 or less, and with the phase of minus 16 millimole per liter or more in a sample of umbilical cord blood or any blood sample within the first hour after birth. If this criteria is not present, we can apply a 10-minute Apgar score of 5 or less, or ongoing resuscitation, for example, assisted ventilation, chest compression, or cardiac medications initiated at birth and continued for at least 10 minutes. The third criteria is the moderate to severe encephalopathy on clinical examination. Then there is another criteria is the EEG abnormality. If it is a must be present to be added at the fourth criteria if we will use selective head cooling. If we will not use selective head cooling, it is not mandatory to present to start the cooling. So who is not for cooling? Infants who should not be routinely cooled include evidence of severe head trauma or intracranial bleeding. Infants less than 36 weeks, and as I told, there is some centers using the 35 or 34 weeks as a cut point, and those more than 6 hours of age. Infant with severe encephalopathy, congenital anomalies, or abnormal chromosomes is controversial. Exclusion criteria, including if there is oxygen requirement more than 80%, and this usually will be with patient with major congenital malformations, congenital heart, or congenital diaphragmatic hernia with lung hypoplasia, major congenital abnormalities, uncontrolled severe clinical coagulopathy, and if the baby is unlikely to survive. So the cooling is either passive cooling or active cooling. And the active cooling includes either whole body cooling or selective head cooling. And the aim is to decrease the body temperature from the normal to reach between 33 degrees to 34.5 degrees for a duration of 72 hours. Then to start the warming after the cooling, which is started after 72 hours of cooling, or if there is a complication mandating to stop the cooling earlier, we will start the rewarming. The rewarming will be at a rate of minimum 0.25 degrees to maximum 0.5 degree per hour over 4 to 12 hours. There is some precautions before we start the procedures to put in mind. We will try to avoid the hypoxemia and hyperoxia. We will try to maintain the brain perfusion, avoiding the hyperperfusion, avoiding the systemic hypotension or hypertension. We're trying to maintain the blood glucose, the pH, the nutrition, and avoid hyperviscosity. Analgesia is a must. Control seizures is a must. Putting in mind that the seizures may be subtle or subclinical, detected only by the EEG. If there is another complication or association, we should treat like treatment of pulmonary hypertension or by high frequency ventilation of nitric oxide or ECMO is if needed. So if there is special consideration during the procedure itself, there is the body physiological response will be some changes, will have some changes during the cooling or during the rewarming. During the cooling, we have the patient will have sometimes bradycardia, sometimes will have prolonged PR and QT intervals, can have arrhythmia, especially if there is drug toxicity, increase the incidence of sepsis and thrombocytopenia, and coagulopathy. Potassium can change during the cooling. If there is acute renal failure, we may have hyperkalemia and will have hypokalemia from the cooling itself. During rewarming, this patient can have hypotension, especially if you rewarm it rapidly, increase in heart rate, decrease in urine output, or electrolyte imbalance. And this patient also can have apnea during rewarming or have seizure. Then we'll talk about the procedure. This is a machine, our machine, Blanketrol 3. This is the machine itself, and this is the machine has two tubings connecting to a blanket. The blanket will put under the patient, and through this tubings, there is water will pass through it. This is a container of the water in the back of the machine. And this was this two, male and female, it's named like this. One will take the water to the blanket, and one will take the water out of the blanket. And this, the machine, the screen of the machine, we are adjusting the temperature that we need. In our unit, we are using 34 degrees. And here, the temperature, the center temperature of the baby will appear through esophageal probe or connected to this area in the front of the machine, and the esophageal probe will be inserted oropharyngeally, to reach the esophagus. I will show X-ray for this in the next slide. And the screen here, it will show the temperature of the water. That is the main way the machine will make cooling or warming of the water according to the reading temperature of the baby to reach the 34 degrees that we adjust. This is X-ray for to detect the side of the probe. We must do the X-ray to detect the place. The place should not pass the diaphragm level. Should be here or can be upper for a little, but should not pass to the diaphragmatic to the stomach. So this one was adjusted after that to this level. So after we diagnose the hypoxic ischemic encephalopathy, we have eligible criteria for to justify for calling. We'll start to prepare our patient and prepare the machine and starting to counsel the parents about the procedure and what the manifestations that they will see during visiting their baby, and will have consent from them. At that time, we are preparing the patient regarding the insertion of the IV lines or central line, peripheral or central, and prefer the central line, vital signs monitoring, sending the basal investigations, blood culture, and to connect the EEG machine, and putting a chart for the vital signs and a chart for output and input. And we'll put the orders or the instructions for the staff about the ventilation, sedation, IV antibiotics, calcium gluconate, magnesium and magnesium sulfate if we'll use, IV fluid, TPN, and we'll instruct about the TFI, total fluid intake, and the investigation. There is some investigation we'll do Q8 to 12 hourly, and some investigation will do Q24 hourly. The one Q12 hours will include the blood gases, urea, creatinine, electrolytes, including sodium, potassium, chloride, and calcium and magnesium. 24 hourly, we'll do coagulation profile and CBC with differential, CRB, liver function test, and bone profile, including calcium, phosphorus, alkaline phosphatase, total proteins, and albumin, and uric acid can be done. Of course, if there is any abnormality from these investigations, we will repeat more frequently to adjust the level in the blood. So I will start to speak about each issue alone. Ventilation. Ventilation is a mandatory for patients undergoing therapeutic hypothermia, either non-invasive or invasive. The aim of the ventilation is that you want to decrease the stress the patient have, to decrease the metabolic rate, because if you didn't ventilate, the basal metabolic rate will increase, and this will counteract the effect of the therapeutic hypothermia, that is its aim mainly to decrease the metabolic rate. So ventilation is mandatory. The care of the ventilator cases and everything will be according to the policy of the unit. And the blood gases will be done as we informed before, Q8 to 12 hourly or Q6 hours, or according to the protocol of each unit. And the aim is to prevent hypocapnia. Putting in mind that in therapeutic hypothermia, the BCO2 decreases by about 3 to 4% for every 1 degree drop in the temperature. So we are keeping the target BCO2 levels of 50 millimeter of mercury as a minimum to avoid hypocapnia, because hypocapnia will exaggerate the CNS problems the patient could have later. Cardiovascular system support. Cooling affects the baby's heart rate and blood pressure and prolongs the PR and QT intervals. The heart rate usually falls to around 80 to 100%, 100 beats per minute at 33 to 34 degrees. If the heart rate of the patient is more than 110, consider that this patient has stress condition, and you must remove this stress to leave the therapeutic hypothermia to work properly. Blood pressure in cooling, it will increase in most cases, and it will decrease on rewarming, particularly if rewarmed too fast. Central access, IV access, if not inserted from the start, better to be inserted, so we can monitor the blood pressure properly. Hypotension should be assessed and managed as per unit hypotension protocol. And putting in mind also that if in spite of that dopamine is the most inotropes used in the therapeutic hypothermia as a vasoconstriction, but the therapeutic hypothermia causing peripheral vasoconstriction, and maybe the dobutamine will be better to use in during cooling if needed. As I told, the dopamine is the most one used in generally, but usually it is better to follow the instructions of the cardiologist according to the echo finding, because some patients, like patients with IDM and patients have hypertrophic cardiomyopathy, for example, should not given dobutamine or epinephrine. Milrinone is recently increased in use, but because it has advantage to decrease the oxygen requirement, oxygen used by the heart, in spite of its increasing the cardiac work, but it causes, most of the cases have diastolic hypotension, and they will need another inotropes to be started with. Sepsis, increased risk of sepsis reported with cooling. We are covering prophylactically with the antibiotics according to the protocol. We are using, usually you can use ampicillin gentamicin, but if there is renal impairment, we can replace the gentamicin with cefotaxime. Fluid management, babies should initially be NPO, and it is the preferred way to keep NPO during the 3 days of cooling. Fluid should be started at 40 to 50 ml per kg per day. This is about 80% of the maintenance, and better to start with 10 to 12.5 dextrose %, and even if the initial dextrose level was high, because usually this patient initially will have hyperglycemia, then with the cooling they will develop hypoglycemia if not replaced good with dextrose. Sometimes we need up to 15% dextrose, so it is better from the start to start with the IV central line. Asphyxiated neonates have high incidence of hypocalcemia, hyponatremia, and hypoglycemia. Potassium disturbances is rare in the therapeutic hypothermia, even during recalling, unless if there is renal failure, it will be high. Calcium gluconate is also very important to be given from the start to prevent the hypocalcemia. So if hypocalcemia will can affect the negatively affecting the cardiac function. Sodium and potassium additives should not be added until there is a good diuresis, serum level permits, weight has fallen below birth weight. Some will keep the sodium high normal to minimize brain edema, like the idea of using hypertonic saline for children for brain edema, but it is not recommended to use hypertonic saline in the neonates with perinatal asphyxia, because there is no studies of this on the neonates. Magnesium sulfate, magnesium level should be kept above high normal or at the level of high normal level. So in our protocol, we are using magnesium sulfate routinely during the 3 days of cooling. Strict input and output monitoring. Follow up closely the potassium, especially because it is fatal if there is hyperkalemia. Once rewarming started, we try to rewarm slowly, because if rewarming happened rapidly, there is increased incidence of hypotension, and at that time we will use, if happened, we will use normal saline, bolus can be used, or we'll start dopamine if needed. CNS. And from the start, we are attaching the EEG monitoring or cerebral function monitoring according to the protocol. Management of seizures is a must, and we should detect the subclinical seizures by the EEG because the seizures will increase the metabolic rate and it will counteract the effect of therapeutic hypothermia. We are doing cranial ultrasound daily until finishing the rewarming and cooling. MRI brain should be considered within 4 to 10 days post-birth, and the best is after 7 days, between 7 to 10 days. And if we did the MRI before 7 days and it is normal, we should repeat it, because initially the MRI in perinatal asphyxia may be normal. Steroid and mannitol should not be used for brain edema. brain edema will be treated by fluid restriction only, and we'll use steroids only if there is shock mandating to use steroids to control the blood pressure because of adrenal insufficiency. Cooling may affect the metabolism of certain drugs, causing accumulation and toxic drug levels at otherwise normal doses. So extra care needs to be taken using sedatives, anticonvulsants, and renal toxic antibiotics. Sedation, as we told before, is a mandatory for this patient because the stress may adversely affect the asphyxiated infant and may influence the therapeutic effect of hypothermia treatment. Monitor for tachycardia, facial grimacing, irritability as per pain scoring charts. Medications that we are using in sedations, including morphine, fentanyl, and midazolam. There is some talking about, or some researches about the morphine, especially the boluses of morphine, if given as a bolus. There is association with bad neurological outcome. There is association with IVH and leukomalacia if given with repeated doses. So it is preferred if you will give as infusion. And if you start with the lower dose. Even you can start with the 10 and not increase after that. Fentanyl and midazolam, we are in our unit, we are using the fentanyl or midazolam. We rarely using morphine. Baby may need to be catheterized if liguria happen because these medications will retain the urine. We must catheterize the patient during sedation. And anticonvulsants medications will follow the protocol, that is starting with phenobarbitone if needed, phosphenotoin, and then levetiracetam with the following cautions due to cooling. Phenotone if used or phosphenotoin if used, they should not be used with lignocaine because there is high incidence of ventricular tachycardia if used together. And if this arrhythmia happened, we must immediately discontinue this medication. And also the cooling will be discontinued until the stabilization of the patient. After stabilization, we can resume again. In our unit, we are using phenobarbitone, levetiracetam, midazolam, and usually they are sufficient for control of seizures. Side effects of cooling include shivering, parenteral anxiety, and cardiac sinus bradycardia, prolonged Q2 interval, hypotension, left ventricular dysfunction, sepsis, coagulopathy, platelet dysfunction, electrolyte disturbances, medication toxicity. Subcutaneous fat necrosis is very rare. We saw through the past 11 years one case only with subcutaneous fat necrosis. It's causing hypercalcemia, and the treatment usually is supportive, and the rule is spontaneous resolution. During rewarming, the patient may have may develop hypotension, especially if we are rewarming rapidly, and if this happened, we should decrease the rate of rewarming. And for example, if you are rewarming at a rate of 0.4 degree per hour, you can decrease it to 0.25 degree per hour, and so on. There is higher risk of seizures, and there is a risk of occurrence of apnea. There is some questions and some studies not reaching final recommendation for this. The difference between selective head cooling and whole body cooling. In the follow-up of studies, there is no much difference in the morbidity and mortality between the two procedures, but the whole body cooling is more easy, doesn't interfere with the monitoring with the EEG. Selective head cooling, if you start, you must have EEG abnormal in the start, and then if after you starting, you can't monitor the brain function or the brain activity through the EEG. And most centers are using the whole body cooling. There is some studies about the mild hypoxic encephalopathy that there is these patients have sequelae and on the long-term follow-up, but until now there is no recommendations to start cooling for it. The third question is if there is early improvement of neurological status. For example, if within the first 1 hour of life, Some patients after resuscitation, usually they will need BBV or CPAP. They will deliver the hypotonic or hypoactive with poor motor reflex, and we will do the blood gases showing the criteria for mixed acidosis. Then after about 30 minutes, we'll find the patients completely active with a nearly normal neurological examination. And the blood gases, if we repeat it during that time, we will find the blood gases improving and the pH passing the 7.1. At that time, we can follow the patient for the next 6 hours, and we can defer the calling until through the 6 hours follow-up. If everything is okay, we can complete the normal care with the monitoring of for the next 48 hours. First question is, what if the patient became worse neurologically during rewarming? Sometimes during the rewarming, after we complete 72 hours, the patient will have seizures, for example. At this case, some centers will stop the rewarming process and will cool again for another 24 hours. But there is no clear studies about this one until now. Then the duration of cooling, it is 72 hours, more or less. There is many studies about this issue. The studies for if we cool for more than 72 hours, there is no significant decrease in the morbidity and mortality. And some studies showed that if we rewarm it after 48 hours, there is reactivation of deleterious inflammatory processes related with premature warming after therapeutic hypothermia. And so until now, the recommendation is the 72 hours. The sixth question is if we are doing continuous monitoring with the EEG, and this EEG showed improvement of the neurological examination before the 72 hours. For us, we are not discontinuing the cooling, we are completing the cooling for 72 hours. But some centers or some experts, they will discontinue the cooling and start rewarm. But it is still recommended to continue the 72 hours. If the hypoxic encephalopathy happened in non-tertiary care facility, the area should start the cooling from there, because there is evidence that aerial passive cooling, the earlier passive cooling is initiated, the earlier target temperature will be reached until transfer to the tertiary care facility. Right. About other neuroprotectives, there is many studies about others, including the main two issues, the erythropoietin and magnesium sulfate. All the studies, no one study reached that to comment that magnesium sulfate or erythropoietin have observed role in neuroprotection. But the studies that recommending magnesium sulfate, because it is not, there is no side effects from it, and there is, and the use of magnesium sulfate, by the way, started for as a neuroprotective in therapeutic hypothermia after they observed that the mothers delivered premature, the preeclamptic mother delivered premature babies. These mothers are receiving magnesium sulfate as a treatment of hypertension before delivery. The incidence of CP of their babies is much less than the incidence of CP for the non-preeclamptic mothers delivered prematurely. From this time, they started to make studies to use magnesium sulfate routinely to the mothers before delivery, especially if there is risk of premature delivery. And the studies started to apply the magnesium sulfate for neonates that having, or those having hypoxic ischemic encephalopathy. For our area, we are using the magnesium sulfate in a dose of 250 milligram per kg per day, once daily for 3 days until the cooling will be finished. The prognosis. In spite of therapeutic hypothermia instituted within 6 hours of insult reduces the adverse neurological outcome. However, around half of the affected infants still suffer adverse outcomes, and the reason for such variation is still unknown. Cognitive dysfunction, hyperactivity, low IQ, hearing loss, visual impairment, CB. But the sure thing is that these manifestations are much less in severity than those didn't receive therapeutic hypothermia. There is one study showed that to prevent one case of death or disability from hypoxic ischemic encephalopathy, you must treat 7 or 8 infants. And for every 8 infants treated, this one of them have any disability. My conclusion, therapeutic hypothermia is the only proved neuroprotective use depending on specific recognized and agreed criteria. Therapeutic hypothermia is applied for moderate to severe hypoxic ischemic encephalopathy. Active cooling should be applied in tertiary care facility with written protocol and guidelines for use, with availability of the equipment, radiology, and blood bank. But cooling should not be delayed and should be started before and during the transportation to the tertiary care facility. Monitoring, fluid therapy, organ support are very important during the cooling and rewarming. Sedation and ventilation are mandatory, so again, ventilation non-invasive or invasive. Yet still there are about 50% have complications on the short and long-term follow-up. Still no clear recommendation for the other neuroprotective apart from the magnesium sulfate and erythrobutene, but no recommendation yet. But we are using magnesium sulfate in our unit. This is the last slide. Thank you.
Thank you so much, Dr. Samira, for your nice presentation. If someone has any question, or we can proceed, you can stop sharing. So we'll reach to our last speaker for today. He will be Dr. Manab al-Najjar. Dr. Manab al-Najjar is an ophthalmology consultant at King Abdulaziz University in Riyadh since 2007. Dr. Manab did his fellowship in ophthalmology from Royal College of Surgeons in Glasgow. Also, he finished his subspecialty fellowship in pediatric and adult retina fellowship from King Khalid Eye Specialist Hospital. He is in charge for the ROB training program at King Saud University. Dr. Manab will give a lecture about ROB, retinopathy of prematurity. Is it evolving? Welcome, Dr. Manab, and you have the mic.
Thank you very much, Dr. Nabil. I am so honored to be with you today. And thank you for this magnificent organization of this symposium, as usual. Now we are talking about the retinopathy of prematurity. Is it changing? Is it evolving, or the same? Still, retinopathy of prematurity is one of the first 3 leading causes of childhood blindness, as one child gets blind from ROP economically, and in calculation, it's almost equal to more than 10 elderly people get disabled by macular degenerations. Prematurity rates always increasing in the last recent few years due to the improvement in ICU and quality managements, which is ranging from almost from 5% in some Northern European countries to more than 15% in some countries like in Middle Africa and Asia. The reported incidence of the ROP, it's variable in the population of infant at risk. In the babies less than 1.5 kg, it ranges from 16 to 56% of premature babies, which is still a large number. And reported according to the 2014 studies, almost more than 50,000 of children get blind worldwide from ROP. Just a few words here about what's called about the epidemics of blindness due to retinopathy of prematurity. Nowadays, we are facing the 3rd epidemic of ROP. It means that there is increased number of the premature of severe retinopathy of prematurity that needs treatment, mainly in low or medium income countries, due to the expansion of intensive neonatal care, often with inadequate quality, low coverage of ROP screening and treatments. While the first epidemic was starting when the invention of the incubators in 1940 to 1950. Still, we are facing the third epidemic, and still we have a lot of work to prevent, or at least to minimize, the blindness to the least number. This is just a map just showing the estimated incidence of vision impairment and blindness from ROP per 100,000 live births. We can see the hot color suggestive of the high mortality or the high incidence of blindness or disability. Mainly, we can see it in countries that involved the third world countries. And while the white colors here in the middle of the Africa doesn't mean that they have a low blindness from our ROP, but unfortunately, because we don't have enough data regarding blindness from ROP. While the first world countries like States, Canada, and like Western Europe, Australia, these countries always the blindness from ROP is ranging from 10 to 45 every 100,000 live births, but still it is high. In our countries, in Arabic countries, it's ranging in the middle range from 10 to 45 children get blind from per 100,000 live births from ROP. So it means that still we have a lot of work and a lot of job to do. So as we know, ROP is a iatrogenic disease, is not congenital, is not hereditary. It is a victim of modern technology, which involves mainly the premature babies, the premature retinal vasculature. Usually it happens in babies less than 1.5 kg or less than 32 weeks gestational age. Although lately we are noticing, especially in many unqualified in ICU, even with the babies more than this borderline, they will develop ROP because of the uncontrolled oxygen use. About the risk factors, it's a multifactorial disease, but the most important risk factor for developing ROP, as everybody knows, is prematurity. More than 50 separate risk factors, dependent and independent risk factors, is identified. But the most important here is the birth weight, gestational age, number of the days oxygen administered. And as we know, the equation is very simple. Lower the birth weight and gestational age, the higher the risk of any ROP and serious ROP that warrant treatment. ROP incidence has remained mostly stable at almost 6% of all screened infants with birth weight less than 1.25 kg. But in infants with gestational age more than 32 weeks has been decreased the incidence of ROP from 5.2% to 1.1%. The recent update, there is a new terminology called a micro-premature infants. A micro-premature infant means the infants that born with less than 750 grams birth weight or gestational age less than 27 weeks. We noticed that the ROP incidence is increased by almost more than 50%, which means reaching up to 10% of premature babies. These babies needs more frequent screening, require more treatment, which would, according to the studies, almost these babies are 77%, more than 2/3 of them, they need treatment. There is exception for the country of the third epidemic that involving the third epidemic of ROP, which is the low or medium income countries. According to the paper published 2016, we found a serious ROP can be happen even with a large gestational age and birth weight. This gives us clue that if any in ICU and the ophthalmologist, if he found that ROP can be happens in babies born more than 1.25 kg or baby born, for example, after 32 or 33 weeks, it means that there is a problem in the quality of an ICU handling the babies, and their protocol should be revised, or they should hire more qualified ophthalmologists. Other important classic risk factors like blood transfusion, intrauterine growth retardation, failure in increasing in weight, respiratory distress, sepsis, multiple apnea, vitamin E deficiency, anemia, seizure. These all, if this is present, increasing the risk of ROP because of the increasing the systemic morbidity of the premature baby. But I will here concentrate on some infant-related risk factor that a lot of talk in the literature and even in our practice we face it. I will concentrate on them. Most important is postnatal weight gain. Postnatal weight gain, we found it that less than 150-gram gain in 10 days after 10th day post-delivery. This is usually associated with the high risk to develop severe ROP. Hyperglycemia, also babies with a high blood sugar responsible for high risk of ROP. Low platelets, if any baby with a thrombocytopenia or platelet count less than 100,000 was associated with a severe disease. And this is, we face it many times in many patients. Hydrocephalus also associated with a severe ROP, but now we found also what's called the outborn infants, infant that those transferred from the external institution or from other hospitals, especially from periphery. Usually they required high level care, more frequent screening and or treatment with laser or injection or surgery. We noticed this recently. Most of the outborn patient or the patient comes to our institution for any reason they associated with severe ROP. Maternal risk factors is the same, multiple birth associated with a high risk, maternal age 3 times fold when the mother is more than 30 years of age. Maternal diabetes, ROP was almost around 80% in diabetic mother group comparing to 15% in control group. Some people are claiming that antenatal steroids, it can reducing or protect against ROP, but this is not conclusive. The new risk factors that recently are published in literature, we have 2 of them. One of them is called the tunica vasculosa lentes. It's ophthalmologically, it's a bedside indicator. It's only be seen by ophthalmologists when using in direct ophthalmoscope. Tunica vasculosa lentes, it is a vascularization of the lens. Usually the lens is a vascular structure that can be, these blood vessels over the lens are regressing around 34 to 35 weeks gestational age. But if it's persistent, after that age, it means there is a large volume of anterior or vascular endothelial growth factor in the eye and gives me clue as an ophthalmologist that this patient, he will develop severe ROP and may he need treatment. Another clue also in the literature is a fundus pigmentation. Lighter fundus pigmentation, especially in the lighter or in the light or fair skin babies, is independent factor associated with the ROP, more aggressive features than the patient with the dark pigmentation. The inferior images we see here, this is a dark pigmented and superiorly the light pigmented fundus. But the question is why? They found that a melanin, it's in the high concentration in the dark people or dark iris, it used as a carrier of the vascular endothelial growth factors to take it away from the eye. So in the light pigmented children or light pigmented fundus, it associated with a less melanin, so less carrying of vascular endothelial growth factor, which is sequestered inside the eye, and this leads to development or increasing development of new vessels and then vitreous hemorrhage and retinal detachment associated with the ROP. So these are the new updated risk factors in the last year. Classification, just a few brainstorming. There's nothing changed, the same according to the site, anatomical location, zone 1, zone 2, zone 3. Zone 1, it is around the optic disc, double the distance between the optic nerve and the macula. This is a zone 1. ROP in this area, it means more worse disease. Zone 2, it is the nasal retina, and the zone 3 is only the temporal crescent of the retina. So what we noticed that if we have any avascularity of the retina within zone 1, it means severe disease. In zone 2, less severe. In zone 3, it is least severe. So usually zone 1 more worse, zone 3 least worse. About the other things is about the staging. The staging into, we have a 5 stages, nothing changed. In suggestive align, it means there is a, you see, as we see in this slide, it's more clear. If development of blood vessels starting from the optic nerve, then it's the veins and the arteriole spreads nasally and temporally. This is the temporal side and this is the nasal side, reaching a stage and then stopped. This is called as a line. This line, we can see there is no volume, just a line. This is called stage 1, like here. Now, when this line acquired the volume, like here, acquired the volume, and he has some sort of, it's called the ridge. This is a stage 2. When this ridge starting developed at the intersection between the vascular and avascular retina, a start of formation of fibrovascular tissue at the ridge, this is called stage 3. And this stage means that this is, we have to intervene as ophthalmologists, either by injection or laser. This is stage 4, it means retinal detachment. These fibrous tissue will contract and this will detach the retina from the choroid, leading to the what's called the subtotal retinal detachment. When the retina is totally detached, it's become like a whitish tissue, white fibrous tissue. This is called the total retinal detachment. Usually the prognosis is very poor in stage 4, but in stage 5, there's zero prognosis and nothing can be done. Other prognostic factors still not changed is what's called the plus disease, because many times pediatricians or in ICU technician, they are called doctors, they are asking me about what do you mean by plus disease? It's a prognostic factors. It means that I have a very severe congestion of the venules and tortuosity of the arterioles, suggestive there is a direct communication between the arterioles and the venules and at the intersection between the vascular and the vascular retina. And this is a poor prognostic signs. Usually if we have a plus disease, I will go further for treatment. This is the main terminology that maybe you should know. No need for further details. There is a many screening algorithms, the protocols. You know, in the Western country, there is very important. The cost is very serious matter for them, because the screening is very invasive procedures financially and even to the babies. Therefore, they are trying to make many algorithms to reduce the babies that needs screening. Therefore, for example, there is one recently, I think in 2020, there's a big randomized controlled trials, and they did it fully trying to find which baby that have a high risk, that 100% sensitive and specific. If using this criteria, they will develop ROP and need to be screening. So the algorithm is called a growth retinopathy study. This was just to reduce the number of the screening babies, and they make some sort of criteria, but we cannot honestly use it in our countries because we need to standardize the things, and we have to make it in our countries. What they noticed, that every baby less than gestational age 28 weeks, less than 1 kg, or as I said, or hydrocephalus, or if he has a failure of weight gain, I simplified by 150 grams every 10 days, these patients have 100% that they will develop some sort of the ROP and should be screening. Any baby that didn't fall with this criteria, they shouldn't be screened. So they found that they reduced the number of the screened babies by almost 27.3%. But we cannot honestly rely on this, because done in specific centers in the United States and in Canada. The last one, its last big studies for ROP was published in 2021. It's called the ICROP 3rd edition. There's nothing a lot changed, except that there's a few terminology has been, which is called ROP regression and ROP reactivation. Why this was updated, this definition? Because of the era of anti-VEGF injection. Nowadays, we are using anti-vascular endothelial growth factors injections in the treatment of the ROP, like, for example, Avastin, like Lucentis, sometimes Eylea. And they found, but the problem with this injection, it is a time limited from 4 to 6 weeks and maximum for 2 months. And after that, it will be regressed. Therefore, usually there is a definition of regression. Usually before in the era of laser, and still when we are doing complete laser, usually within 1 or 2 weeks, total regression of the disease, and this will be irreversible if it's done properly and complete. But if we are giving injection, the problem is reactivation after 6 to 8 weeks. Therefore, if the patient is not followed up, or is the patient not seen by ophthalmologist, reactivation, it will be sometimes very severe, and the disease will progress to retinal detachment and then blindness. Therefore, we have to identify the regression and to write patient or the baby is regressed under the effect of Lucentis. Patient is regressed under the effect of laser. So therefore, the next follow-up doctor, he will know exactly what's going on. And also, we have to see also to write a new terminology about the reactivation. For example, the baby was reactivated after after finishing after 6 weeks of giving intravitreal injection or Avastin. Management, still we have the same management. The laser is the mainstay of management. Intravitreal injection, according to the beat ROP, we are using it only in these conditions when, for example, we don't have facility of laser, or example, according to the beat ROP study that published in 2011 in patient with zone 1 disease, when the disease only in this area is small. So it means that if I will do the laser, I will ablate large area of the retina, and this the patient will comes with a tunnel vision. So I can, in zone 1 or posterior zone 2, I can give injection to give a time for the new blood vessels to grow further and reducing the laser that needs ablation. But usually when we are giving injection, as I said before, we have to follow the patients very frequently, and we cannot discharge the patient unless I'm sure that the patient has some place to get a follow-up by the qualified ophthalmologist. This is just a table to showing the difference between the laser and the injection. Bevacizumab, for example, Avastin. Usually the laser is more invasive. It takes about 1 to 2 hours. It needs more expertise ophthalmologist. But while injection is very quick procedure, doesn't destroy the retina, have less effect on the refractive error, but they have a risk of endophthalmitis, although it's very rare because we are giving some injection inside the eye. Sometimes, if not done under full aseptic condition, usually it's associated with the endophthalmitis. Why the laser? It's give me a permanent effect, although there is some sort of complication in form of high refractive error, like high myopia or anisometropia. And the regression usually starting after 1 to 2 weeks, after injection 1 to 2 days. But the problem here with the injection is reactivation and the follow-up. Okay. In addition, that is many people, they don't have exact data regarding the systemic side effect or neurological development in the patient that underwent vascular endothelial growth factors, because the serum vascular endothelial growth factors is totally decreased after giving anti-VEGF medications. And we know that a vascular endothelial growth factor is it is a very vital substance for neurodevelopment and also for the lung and the heart developments. Lately, there is a lot of the papers in the literatures, they are talking about the role of the propranolol, because you know the propranolol or the beta adrenergic blockers, they found they have a great role in managing some vascular lesions in the eye, like capillary hemangioma, and they found that propranolol is highly affecting in inhibiting the increase of vascular endothelial growth factor. And you know that the vascular endothelial growth factor, this is the main factor that's responsible to development of active ROP and detachment. During the last 6 years, there's 5 major studies being published for the use of the oral propranolol as a treatment, but mainly to prophylaxis, to prevent or decrease the progression of the ROP to treatment stage. Usually you are using it in the patient with a high risk. If we don't have ophthalmology facility, I don't want the disease to progress, and I will give some sort of the beta blocker to reduce the vascular flow or the blood flow to the eyes. But these studies always is faced or it's meted by the systemic side effect like bradycardia, hypotension, especially in the extremely low birth weight preterm infants. Hypoglycemia is one of the most common side effects in a prolonged treatment, especially if the patient is using this medicine more than 5 months or in doses from 2 to 15 milligram per kg per day. Therefore, the best dose was recommended to starting, if we want to give it, to start with 0.5 milligram per kg per day on the first day, then doubled in the second day, then 1.5 milligram the third day, and continuous for 1 and 2 months under full monitoring, cardiac and blood sugar monitoring. Because of these systemic side effects, 2 studies, they are trying to use what's called a micro drops, okay, using propranolol drops by preparation in the lab, but unfortunately, it's very ineffective in controlling or preventing the progression of the ROP, although there is no systemic side effects. This option, it's promising, but needs a lot of studies, especially if we found the exact or the correct dose. Also, there is a talk about the supplemental oxygen in high-risk babies. Usually, as we know from the pathophysiology of retinopathy of prematurity, we have 2 phases, vasoobliterative phase, which is the first phase, and vasoproliferative phase, which is the second phase. Usually, in the second phase, it begins to develop after 32 weeks gestational age. Usually, the main issue here is the retinal hypoxia, because the retinal maturation is retina becoming more thick, and retina, it needs more oxygen. So usually the ROP become aggravated because of this. Therefore, what they are claiming that if we maintaining the saturation of the oxygen about the 95% could reduce the disease progression. One big randomized controlled trials, it's called the STOP ROP, supplemental therapeutic oxygen for retinopathy promediati, used 2 oxygen saturation regions and shows a decrease in the progression of pre-threshold or high-risk ROP to threshold, with the high saturation ranging from 96 to 99%. But the problem in this, for how long I have to use high oxygen concentration? And you know, high oxygen concentration it's okay, it's maybe beneficial to the eye, but it's toxic to the other organs. So therefore, we cannot use it. It needs more monitoring and more studies to find the exact also concentration and the exact protocol. At the end, in the conclusion, we can find laser treatment remains the standard therapy for the ROP. It gives me a permanent involution and resolution, but the problem is with the systemic, with the side effect in long term, like a high refractive error. But at least the patient, he will not develop retinal detachment. Antivascular endothelial growth factors are currently used, but the optimal dose treatment, it needs to be determined to gives me a permanent. Now we are talking in the literature about what's called a long-standing anti-VEGF agent. For example, Eylea, it's one of the rapid, it can give me effect until 3 months if I will give intravascular endothelial growth factor. But the problem with the Eylea, I don't want also to give or to suppress the vascular endothelial growth factors for 3 months. I want to give just for 1 or 6 weeks, just to reduce the load of vascular endothelial growth factor, but I need it for normal physiological development of the retina. Therefore, this is not an option. But the only option here is to give an appropriate dose that can only target pathological vascular endothelial growth factor, not the physiological one. Currently, in high-risk ROPs, there is no type of treatment had been established exactly for prophylaxis, but it's like a propranolol that prevent the progression. It's a great promise, but the precise indication, efficacy, and safety, and also the optimal dose needs to be determined in further researches. Just a few words about the telemedicine. Now, because of the inability to be or availability of expertise ophthalmologists, now especially in Saudi Arabia, already they started telemedicine for ROP in many government hospitals, especially in the periphery, in the south and the north, which we are using a wide-angle retinal images like RITCAM, and the images is sending to center in King Khalid Eye Specialist Hospital, reading by ophthalmologist and giving the clue if the patient needs treatment. Either they will send him to a qualified center for the treatment. This honestly reducing dramatically the blindness from ROP in the Saudi Arabia, and I hope to progress. I hope this program to be implemented also in the private hospitals. By this slide, I'm finishing my my presentation. Thank you very much for listening. I'm ready for any questions. Thank you.
Thank you, Dr. Manal, for your nice explanation, presentation. I have just for you some inquiry. You spoke now about new modalities and the new treatment, but we did not implement this in our unit. So if you can help to supply us with your protocol, if we can update. This is as a prophylaxis, but I want to come to the treatment. What I read in the literature that most of the centers now are widening the Lucentis injection early and more than using laser. If I will see that the laser is destroying the area or the retina, which will be totally permanent, and the child will have a tubal vision. And he is not saved totally. He will have just a tubal, or he will lose the side vision on the permanent area of the retina. If like this, why you are not implement Lucentis more aggressively and more early? And if I found that patient has high risk ROP and I'm still following up every week, if I will inject early, this will affect or no?
No, the problem with the antivascular endothelial growth factor like Lucentis of Avastin, it should not be given just in a high, it should be given only in the patient that he warrants treatment, reaching what's called as an active ROP1, which means that the baby is reaching the stage, for example, if there is a plus disease, if there is a stage 3, if there's zone 1 or zone 2, I will go, instead of doing laser, I will go for injection. But as a prophylaxis, this is not implemented anywhere. Why? Because a prophylaxis, the problem that I need a vascular endothelial growth factor. The problem with the Lucentis and the Avastin, they are blind diseases. They are blind medicine. We have to target it, the physiological and the pathological. Therefore, for example, we are not giving Eylea. Eylea, we are giving it, it will halt everything for 3 months. But I need, if I will give Avastin, for example, just to reduce the activity of the disease for a while until the blood vessels will grow further. If I have a place to follow up the patients, for example, until reaching, for example, anterior zone 2 or zone 3, if I will give here Avastin, it will reduce it. It will again, it's halted again for another 3 months. Therefore, it's a best option if the patient, for example, in zone 1 or posterior zone 2, and this is what we are using in our in university hospital, in King Khalid University Hospital. Patient zone 1, posterior zone 2, we don't want to burn, we are going for injection. If, for example, after 4-6 weeks, activation in the same level, we'll inject again. But if the patient going for mid or anterior zone 2 or early zone 3, for example, in the periphery, and the patient, maybe he will lose follow-up and I cannot do, I will go and laser him. Although I will ablate only the periphery. Unless sometimes the patients, for example, I will give injection. If, for example, bad view, I cannot see exactly the retina, I cannot laser him. The problem with the private hospital here, it's because there is no expertise ophthalmologist to do laser. Laser still is the mainstay of management. Agree with you, we will use anti-VEGF, but for specific cases, not widespread. Okay, because of that, we have many cases, they are coming, unless the patient is in zone 1 or posterior zone 2. Because if patient in high risk or I just suspicious and I don't want to follow him, I will give him anti-VEGF, I will halt everything. And I better to keep him, follow up to high risk, to give a place for vascular endothelial growth factor to work, just to retina to develop more. Because if I'll give anti-VEGF, it will stop retina development and the development of a new blood vessels.
Thank you so much. Anyone want to ask? So, okay, thank you, Dr. Manar. This was our last lecture. With this, we come to the end of the first day. I thank all the speakers very much for your time, for your knowledge. And I want to thank also the attendees. We reached to the end and still we have 550 attendees. So thank you so much, and we will meet again tomorrow, inshallah, 4 p.m. Riyadh local time. Thank you so much, and salam alaikum.